Hello and welcome. Do you want to successfully complete the D236 OA exam? Then you are in the right place. Our website has free questions and answers for the D236 OA exam. We know OA exams are tough, so our guides and practice questions are all free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from endocrine regulation, fluid dynamics, electrolyte imbalance, genetic pathology, musculoskeletal integrity. So, let's get started.
Question 1. A patient experiences significant blood loss after a traumatic car accident, causing their blood pressure to drop rapidly to dangerous levels. Which specialized kidney cells would first detect this pressure change and initiate the compensatory hormonal cascade to restore normal circulation and perfusion? A. Juxtaglomerular cells near the glomerulus. B. Macula densa cells, distal tubules. C. Osteoblast cells within kidney nephrons. D. Endothelial cells lining renal arterioles.
Can you guess the answer?
Correct answer. A. Juxtaglomerular cells near the glomerulus. Juxtaglomerular cells are specialized smooth muscle cells located near the glomerulus that detect pressure drops and release renin, thus beginning the entire RAS cascade aimed at elevating blood pressure back toward normal. Option B is incorrect because macula densa cells detect low sodium concentrations within distal tubules, not pressure changes directly. They signal indirectly through sodium sensing, but are not the primary cells that release renin first. Option C is incorrect, because osteoblasts are bone-building cells involved in skeletal mineralization and calcium deposition. They have no role within the kidney or the detection of blood pressure changes in vascular perfusion. Option D is incorrect, because endothelial cells line blood vessels throughout the body and help regulate vascular tone, but they do not secrete renin or serve as primary pressure detectors within the kidney's filtration apparatus. Alright, let's dig into the kidney's pressure detection system because this question gets at the very first step of the RAS cascade. Juxtaglomerular cells sit right next to the glomerulus where blood enters the kidney's filtering apparatus. These specialized smooth muscle cells work like tiny pressure sensors. When blood pressure drops after an injury like a car accident, they sense the change in vessel wall stretch and release renin directly into the bloodstream. That single release kicks off the whole hormonal chain that eventually raises blood pressure back to safer levels. Now the other options miss the mark for clear reasons. Macula densa cells sit in the distal tubule and sense sodium concentration, not pressure directly. Osteoblasts build bone, so they belong in the skeletal system entirely. Endothelial cells line vessels and regulate tone, but they do not secrete renin. The key word here is first detect the pressure change. That points straight to the JG cells near the glomerulus. Here's a what you D236 OA exam tip for you. When you see a question about the first step in RAS activation, remember JG stands for juxtaglomerular, which sounds like just got the pressure signal. JG equals just got the signal, renin released. Question 2. A nursing student is explaining how renin works after it leaves the kidneys. Her instructor asks what renin actually does once released into the bloodstream and what the immediate next step in the hormonal cascade involves before reaching the lungs for conversion. A. Renin directly constricts smooth muscle walls. B. Renin stimulates aldosterone release adrenally. C. Renin converts angiotensinogen into angiotensin. D. Renin triggers ADH secretion pituitary.
Can you guess the answer?
Correct answer. C. Renin converts angiotensinogen into angiotensin first. Renin is an enzyme that specifically cleaves angiotensinogen, a protein produced by the liver, into angiotensin I. Angiotensin I then circulates inactively until reaching the lungs for further conversion into active form. Option A is incorrect because renin itself has no direct vasoconstrictive properties on smooth muscle. That action belongs to angiotensin II later in the cascade, after conversion by angiotensin-converting enzyme within lung tissue. Option B is incorrect, because renin does not stimulate aldosterone release directly. Aldosterone secretion from the adrenal cortex happens later in the pathway, driven specifically by angiotensin II, rather than renin itself. Option D is incorrect, because ADH release from the pituitary gland is stimulated by angiotensin II, not renin directly. Renin simply kicks off the pathway that eventually leads to pituitary involvement downstream. Let's trace the very first enzymatic step of the ROS pathway to see why this answer stands alone. Once the juxtaglomerular cells release renin into the bloodstream, renin has one specific job. It finds a protein called angiotensinogen that the liver constantly produces and releases into circulation. Renin acts like a pair of scissors, cleaving angiotensinogen into a smaller piece called angiotensin I. At this stage, angiotensin I is still inactive and just circulates through the blood until it reaches the lungs. Option A misses, because renin itself does not constrict vessels. That job belongs to angiotensin II much later in the cascade. Option B is wrong because renin does not pull the aldosterone trigger directly. Aldosterone release waits for angiotensin II to stimulate the adrenal cortex. Option D falls flat, because ADH release from the pituitary is also an angiotensin II effect, not a renin effect. Renin simply starts the chain reaction. Here's a D236 OA exam tip for you. Think of renin as a pair of scissors cutting angiotensinogen into angiotensin I. Renin cuts. Angiotensinogen is the fabric. Angiotensin I is the first piece that falls. Scissors first, everything else downstream. Question 3. Michael has chronic heart failure with persistent activation of his ROS, leading to worsening peripheral edema and pulmonary congestion. Which combination of physiological effects from angiotensin II best explains why his fluid overload keeps getting worse over time despite treatment efforts? A. Vasodilation plus reduced sodium excretion urinary. B. Bronchoconstriction plus decreased thirst sensation hypothalamic. C. Increased gastric motility plus potassium retention renale. D. Vasoconstriction plus aldosterone release and ADH.
Can you guess the answer?
Correct answer, D. Vasoconstriction plus aldosterone release and ADH. Angiotensin II causes direct vasoconstriction, stimulates aldosterone release for sodium and water retention, and triggers ADH secretion for additional water reabsorption. This triple effect drives Michael's worsening fluid overload and edema. Option A is incorrect because angiotensin II causes vasoconstriction, not vasodilation, and it drives sodium retention rather than excretion. Both actions raise blood pressure and fluid volume rather than reducing them. Option B is incorrect because angiotensin II does not cause bronchoconstriction, and it actually stimulates thirst through hypothalamic activation rather than decreasing it. These options reverse the actual physiological responses. Option C is incorrect because angiotensin II does not increase gastric motility, and it promotes potassium excretion through aldosterone rather than potassium retention. This combination reverses the actual renal handling of electrolytes. Alright, to understand Michael's worsening fluid overload, we have to look at everything angiotensin II does once it forms in the lungs. Angiotensin II hits 3 different targets that all push blood pressure and fluid volume upward together. First, it directly constricts blood vessels, squeezing them tighter and raising resistance. Second, it tells the adrenal cortex to release aldosterone, which makes the kidneys hold on to sodium and water. Third, it triggers the posterior pituitary to secrete ADH, locking in even more water reabsorption at the collecting ducts. In a healthy person, this triple response saves your life when pressure drops. But in chronic heart failure, the RAS keeps firing even when the body already has too much fluid. Option A is backwards. Angiotensin II constricts, not dilates, and it retains sodium rather than dumping it. Option B reverses the reality again. Angiotensin II does not touch airways and actually increases thirst through the hypothalamus. Option C is also wrong because aldosterone pushes potassium out, not in, and angiotensin II does not ramp up gastric motility. Here's a What You Do ID D236 OA exam tip for you. Memorize the angiotensin II triple threat as the 3 V words: vasoconstriction, volume retention through aldosterone, and vasopressin, which is another name for ADH. 3 verses. 1. Flood. Question 4. A respiratory therapy student asks why patients on certain hypertension medications sometimes develop a chronic dry cough. Understanding where a key RAS conversion happens helps explain this side effect. Which organ is responsible for converting the inactive precursor into its active form? A. Liver, through hepatic enzymatic activity. B. Lungs, through angiotensin-converting enzyme. C. Kidneys, through distal tubule processing. D. Adrenal glands, through cortical secretion.
Can you guess the answer?
Correct answer. B. Lymphocytes, lungs, through angiotensin-converting enzyme. The lungs contain angiotensin-converting enzyme, which transforms inactive angiotensin I into active angiotensin II. ACE inhibitor medications block this conversion in pulmonary tissue, which explains the characteristic dry cough side effect. Option A is incorrect because the liver produces angiotensinogen, the starting substrate, but it does not convert angiotensin I into angiotensin II. That specific enzymatic step happens in pulmonary vascular endothelium instead. Option C is incorrect because the kidneys release renin and are the target organ for many RAS effects, but they do not perform the conversion of angiotensin I into angiotensin II within their distal tubules. Option D is incorrect because the adrenal glands release aldosterone when stimulated by angiotensin II, but they do not perform the conversion from angiotensin I. Their role comes later in the downstream hormonal cascade. Let's dig into why an ACE inhibitor can give someone a dry hacking cough, because the answer sits right where the conversion takes place. The lungs do more than move oxygen. They also host an enzyme called angiotensin-converting enzyme, or ACE, sitting on the inner walls of pulmonary capillaries. When angiotensin I floats through the lung blood vessels, ACE chops it into its active form, angiotensin II. That conversion is the reason the lungs matter in RAS at all. Now ACE inhibitor drugs like lisinopril block this conversion, which is how they lower blood pressure. But ACE also breaks down a substance called bradykinin. When the drug blocks ACE, bradykinin builds up in the lungs and triggers that characteristic dry cough. Option A is wrong, because the liver only makes the starting material, angiotensinogen, and never performs the angiotensin I to II step. Option C is wrong, because the kidneys released renin earlier and now act as a target of angiotensin II, but they do not handle this particular conversion. Option D is wrong, because the adrenal glands release aldosterone downstream after angiotensin II has already formed. Here's a WEDUDD 236 OA exam tip for you. Link the dry cough to the lungs using ACE equals air conversion engine. ACE lives in the lungs, and when you block it, the lungs complain with a cough. Air conversion engine in the air organs. Question 5. A patient with primary hyperaldosteronism presents with persistent hypertension, muscle weakness, and abnormal lab values. Understanding what aldosterone actually does at the kidney level helps predict which specific electrolyte pattern would appear on this patient's comprehensive metabolic panel results. A. Sodium retention and potassium excretion. B. Calcium retention and magnesium excretion. C. Phosphate retention and chloride excretion. D. Bicarbonate retention and hydrogen retention.
Do you know the answer?
Correct answer. A. Sodium retention and potassium excretion. Aldosterone acts on kidney tubules to reabsorb sodium and water while excreting potassium. This produces the classic hyperaldosteronism pattern of elevated sodium, low potassium, fluid retention, and resulting hypertension seen clinically. Option B is incorrect, because aldosterone does not primarily regulate calcium or magnesium balance. Those electrolytes are controlled by parathyroid hormone, calcitonin, and vitamin D rather than by adrenal cortex mineralocorticoid hormones. Option C is incorrect, because aldosterone has no significant role in phosphate or chloride regulation. Phosphate handling is tied to calcium regulation through parathyroid hormone activity, rather than aldosterone mineralocorticoid signaling. Option D is incorrect, because aldosterone indirectly promotes hydrogen excretion rather than retention, and while it influences bicarbonate handling, the primary electrolyte pair it controls remains sodium retention paired with potassium excretion. Primary hyperaldosteronism is basically the body's ROS pump stuck on high, and the lab pattern falls right out of what aldosterone normally does. Aldosterone works at the distal tubule and collecting duct of the kidney. It tells those cells to pull sodium back into the blood while pushing potassium out into the urine. Water follows the sodium, so volume goes up, pressure goes up, and potassium drops. That is exactly why this patient shows hypertension, muscle weakness, and low potassium on the panel. The muscle weakness comes from hypokalemia, interfering with normal muscle cell firing. Option B is wrong, because calcium and magnesium are controlled mostly by parathyroid hormone, calcitonin, and vitamin D. Aldosterone has essentially nothing to do with them. Option C is wrong because aldosterone does not move phosphate or chloride in any meaningful way. Option D is wrong because aldosterone actually promotes hydrogen excretion, not retention, and can cause a mild metabolic alkalosis when overactive. Here's a D236 OA exam tip for you. Remember the aldosterone trade deal using the phrase save sodium, spend potassium. Sodium in, potassium out. 2SS means save. 2PS means push out. Save sodium, spend potassium. Question 6. A patient with severe left-sided heart failure develops pink, frothy sputum, crackles throughout both lung fields, and significant dyspnea when lying flat. Which specific pressure mechanism best explains why fluid is being pushed from his pulmonary capillaries into the alveolar spaces? A. Decreased oncotic pressure plasma proteins. B. Increased capillary permeability inflammation response. C. Elevated hydrostatic pressure pulmonary circulation. D. Lymphatic obstruction causing drainage failure.
Do you know the answer?
Correct answer. C. Elevated hydrostatic pressure pulmonary circulation. Left-sided heart failure causes blood to back up into pulmonary circulation, raising hydrostatic pressure in lung capillaries. This elevated pressure pushes fluid out of vessels into alveoli, producing the classic pulmonary edema picture. Option A is incorrect, because decreased oncotic pressure typically causes generalized edema from low albumin states like liver cirrhosis or kwashiorkor, not the acute pulmonary edema specifically driven by cardiac pump failure mechanics. Option B is incorrect, because increased capillary permeability drives inflammatory edema seen in burns, sepsis, or allergic reactions. This patient's pulmonary edema stems from pump failure rather than inflammatory vascular changes within lung tissue. Option D is incorrect, because lymphatic obstruction produces localized swelling like lymphedema after surgery or from tumor blockage. It does not explain the acute pulmonary edema pattern seen in left-sided heart failure presentations. Pink frothy sputum is one of the most recognizable signs in all of nursing, and it takes us straight to a pressure-based problem. In left-sided heart failure, the left ventricle cannot push forward all the blood that arrives from the lungs. That blood backs up into the pulmonary veins, and then into the pulmonary capillaries. As blood piles up, the hydrostatic pressure inside those capillaries climbs higher and higher. Hydrostatic pressure is simply the outward push of fluid against vessel walls. Once that push exceeds what the capillary can hold, fluid leaks straight into the alveolar spaces where air belongs. That produces the wet crackles, the pink frothy sputum, and the orthopnea we see here. Option A, low oncotic pressure, would cause edema too, but usually in the form of general body swelling from low albumin, not acute pulmonary edema from pump failure. Option B, increased permeability, fits burns, sepsis, or anaphylaxis rather than backed up cardiac pressure. Option D, lymphatic blockage, gives localized swelling like lymphedema in an arm, not rapid flooding of lung tissue. Here's a D236 OA exam tip for you. When you see pink frothy sputum plus left heart failure, think of a traffic jam pushing fluid out of the highway. Hydrostatic pressure equals the push. Push too hard, fluid leaks out. Pump fails, pressure builds, alveoli flood. Question 7. A malnourished patient with severe liver cirrhosis presents with massive ascites and generalized pitting edema, despite having normal blood pressure and no cardiac dysfunction. Which pathophysiological mechanism most directly explains this unusual fluid distribution pattern throughout her body? A. Sympathetic nervous system overactivation causing vasoconstriction. B. Low albumin reducing capillary oncotic pressure. C. Excessive aldosterone causing pure sodium retention. D. Mechanical blockage of thoracic duct.
What do you think is the answer?
Correct answer. B. Low albumin reducing capillary oncotic pressure. Cirrhosis impairs hepatic albumin production, lowering plasma oncotic pressure. Without sufficient pulling force from albumin, water leaks out of capillaries into interstitial spaces and body cavities, producing ascites and generalized peripheral edema. Option A is incorrect, because sympathetic overactivation would raise blood pressure and cause vasoconstriction rather than edema formation. This patient's fluid shift stems from protein deficiency rather than autonomic nervous system dysfunction directly. Option C is incorrect, because pure aldosterone-driven sodium retention would primarily cause hypertension and circulating volume overload rather than the protein loss pattern seen here. Albumin deficiency better explains her clinical presentation. Option D is incorrect, because thoracic duct blockage causes chylothorax or localized lymphatic edema, not the widespread abdominal ascites and generalized pitting edema pattern characteristic of hepatic albumin synthesis failure. Cirrhosis edema looks strange at first because blood pressure is normal and the heart works fine, yet fluid sits in the belly and in the legs. The key is what the liver is failing to make. A healthy liver produces albumin, the single biggest protein in plasma. Albumin acts like a magnet inside the capillaries, pulling water back in through what we call oncotic pressure. When cirrhosis destroys working liver cells, albumin levels drop. Without enough albumin, the pulling force inside the vessels weakens. Water that normally gets yanked back into the bloodstream now leaks out and stays in the interstitial space. In severe cases, it pools in the peritoneal cavity as ascites and gives generalized pitting edema too. Option A is off target because sympathetic overactivation would raise blood pressure and cause cool extremities, not the protein-starved fluid shift we see here. Option C is wrong because pure aldosterone excess produces hypertension and volume overload in vessels, not albumin-deficient edema patterns. Option D is wrong because thoracic duct obstruction causes chylothorax or arm lymphedema, not widespread abdominal and peripheral swelling from liver disease. Here's a D236 OA exam tip for you. Link low albumin to fluid leaks using the phrase no albumin, no anchor. Albumin holds water inside the vessel like an anchor holds a boat. Take away the anchor and water drifts out. No albumin, no anchor, water leaks. Question 8. During recovery from major abdominal surgery, a patient develops decreased lung expansion, shortness of breath, and muffled heart sounds. Imaging confirms fluid has accumulated within body cavities rather than remaining in vessels. Which clinical term best describes this fluid distribution problem? A. Dependent edema in lower extremities. B. Generalized anasarca throughout body tissues. C. Dilutional hyponatremia from water overload. D. Third spacing into serous body cavities.
Can you guess the answer?
Correct answer. D. Third spacing into serous body cavities. Third spacing refers to fluid accumulation within body cavities rather than intracellular or vascular compartments. Pleural effusion limits lung expansion and pericardial effusion muffles heart sounds, both classic presentations of sequestered fluids clinically. Option A is incorrect because dependent edema describes fluid pooling in lower extremities due to gravity and venous stasis, not the cavity-based fluid sequestration pattern described by pleural and pericardial involvement here. Option B is incorrect because generalized anasarca refers to diffuse subcutaneous edema throughout body tissues, not specifically the trapping of fluid within serous cavities like the pleural or pericardial spaces this patient shows. Option C is incorrect because dilutional hyponatremia is a sodium concentration problem from excess water in circulation, not a description of where fluid physically accumulates anatomically within body compartments after surgical procedures. Third spacing is one of those terms that confuses people until you see where the fluid actually goes. The body normally holds fluid in two main places. Inside cells, we call the intracellular space, and inside vessels, we call the vascular or intravascular space. When fluid leaks out and parks itself somewhere else, like the pleural cavity, the pericardial sac, or the peritoneum, clinicians call that the third space. This patient shows two classic third space collections. Fluid in the pleural cavity limits how much the lungs can expand, causing dyspnea. Fluid in the pericardial sac muffles heart sounds because the beats are now happening inside a water balloon. Both are predictable after major abdominal surgery when inflammation, protein loss, and fluid shifts pile up. Option A is wrong because dependent edema means gravity-pooled swelling in the feet and ankles, not fluid sequestered inside body cavities. Option B, anasarca, describes body-wide puffy subcutaneous swelling rather than targeted cavity collections. Option C, dilutional hyponatremia, is a sodium lab finding, not a description of where fluid physically lives. Here's a big D236 OA exam tip for you. Remember third spacing as the third address for fluid. First address, inside cells. Second address, inside vessels. Third address, inside body cavities. 3 addresses. Third one is trouble. Question 9. A nurse on a medical floor needs to track fluid status changes in a heart failure patient over several shifts. Which combination of assessment methods provides the most reliable daily information about whether the patient is gaining or losing excess fluid volume? A. Daily weights plus intake and output. B. Skin turgor plus oral mucous membrane. C. Capillary refill plus peripheral pulse strength. D. Blood pressure trends plus heart rate.
Can you guess the answer?
Correct answer. A. Daily weights plus intake and output. Daily weights catch fluid changes early since 1 liter of retained fluid equals roughly 1 kilogram gained. Combined with intake and output tracking, this gives the clearest picture of fluid balance over time. Option B is incorrect because skin turgor and mucous membrane assessment provide useful but less sensitive data about hydration. They tend to lag behind weight changes and are affected by age-related skin elasticity changes in older adults. Option C is incorrect because capillary refill and pulse strength reflect perfusion status rather than fluid volume specifically. These signs change late in volume depletion and are not the primary markers for daily fluid balance monitoring. Option D is incorrect because blood pressure and heart rate trends show compensatory responses rather than actual volume status. Compensation can mask significant fluid shifts until decompensation occurs, making weights and intake output far more reliable. When you need to track fluid status shift by shift, weights and intake output beat every other assessment method because they catch small changes early. 1 liter of retained fluid in the body weighs about 1 kilogram or roughly 2.2 pounds. That means if a heart failure patient gains 1 kilogram overnight on the scale, they are holding an extra liter of fluid somewhere, often before you can see it on their ankles or hear it in their lungs. Intake and output adds the other half of the picture. If you pour in more than they put out across a 24-hour period, the difference lives somewhere inside them. Together, these two tools give you hard numbers. Option B sounds right in nursing school, but skin turgor and mucous membranes lag behind real fluid changes and also degrade with age, so they are less reliable in older adults. Option C, capillary refill and pulse strength, tell you about perfusion rather than volume. Option D, blood pressure and heart rate change as a response to volume shifts but can stay stable for a long time through compensation, which hides deterioration until the patient crashes. Here's a D236 OA exam tip for you. Remember the fluid tracking rule using the phrase 1 kilo equals 1 liter. Weight on the scale plus numbers on the paper equals the truth about fluid. 1 kilo, 1 liter, one reliable answer. Question 10. A massage therapist recommends Epsom salt baths to a client with swollen ankles after long shifts on her feet. Which physiological principle from Starling's law of capillary forces best explains why this traditional home remedy actually reduces the swelling effectively? A. Hydrostatic pressure pushes fluid into vessels. B. Capillary permeability decreases in warm water. C. Osmotic pressure pulls fluid from tissues. D. Lymphatic drainage accelerates through heat exposure.
What do you think is the answer?
Correct answer. C. Osmotic pressure pulls fluid from tissues. Epsom salt baths create a hypertonic solution outside the swollen tissue. Osmotic pressure pulls water from higher concentration inside tissues toward lower concentration in the bath, reducing interstitial fluid and visible swelling. Option A is incorrect, because hydrostatic pressure pushes fluid out of vessels, rather than pulling it back in. This is the force that originally caused her dependent edema from standing all day, not the mechanism reducing it. Option B is incorrect, because capillary permeability does not meaningfully decrease in warm water. Changes in permeability relate to inflammatory mediators like histamine, rather than external water temperature during topical soaking therapies. Option D is incorrect, because while heat can increase lymphatic flow modestly, the primary mechanism behind salt bath swelling reduction involves osmotic gradients pulling water outward, rather than accelerated lymphatic drainage through vessels. The Epsom salt bath question is really about osmosis, and Starling's forces make the mechanism click. When you soak swollen ankles in a salt water bath, the water outside your skin is now saltier than the fluid inside your tissues. Water always moves from where it is less concentrated to where it is more concentrated to balance the solutes out. So water leaves the swollen interstitial tissue and travels outward into the bath water. That is, osmotic pressure doing its job. The visible result is smaller ankles because you literally drew water out of the tissue through the skin. Option A is backwards because hydrostatic pressure pushes fluid out of vessels, which is actually how her ankles got swollen after standing all day. Option B is wrong, because warm water does not meaningfully change capillary permeability, which is controlled by inflammatory chemicals like histamine, not by bath temperature. Option D is tempting because heat does speed up lymph flow a little, but that is not the main reason salt baths work. The salt is the star, not the heat. Here's a D236 OA exam tip for you. Think of osmotic pressure as the ocean pull. Salty ocean water sucks fresh water toward it. Osmotic starts with O, ocean starts with O. Pull water outward. Osmotic equals ocean equals outward pull. Question 11. Diane finishes a long summer marathon and presents to the medical tent with flushed skin, extreme thirst, reduced urine output, and confusion. Lab results show sodium levels well above the normal range. Which mechanism most likely caused her specific electrolyte problem? A. Excess sodium intake from sports drinks. B. Renal failure, causing sodium retention acutely. C. Hyperaldosteronism from chronic stress hormones. D. Water loss through sweat during exertion.
Do you know the answer?
Correct answer. D. Water loss through sweat during exertion. Prolonged physical exertion causes heavy water loss through sweating that exceeds sodium loss. This concentrates remaining sodium in the bloodstream, producing hypernatremia symptoms like flushed skin, intense thirst, oliguria, and confusion, see in Diane's case. Option A is incorrect, because sports drinks contain electrolyte concentrations designed to match sweat losses. Excessive intake would more likely cause mild hypernatremia, only in rare overconsumption, not typically explaining acute marathon dehydration presentations. Option B is incorrect, because acute renal failure during a marathon would cause many other symptoms beyond sodium elevation, including massive creatinine changes and oliguria from kidney injury, rather than simple water-based hypernatremia presentations. Option C is incorrect, because hyperaldosteronism from chronic stress develops gradually over time and produces sustained hypertension. Diane's marathon story is a classic hypernatremia setup, and the mechanism comes down to what her body was losing through sweat. Sweat looks salty, but compared to blood plasma, it actually contains proportionally more water than sodium. When you sweat heavily for hours in summer heat, you lose large volumes of water while only losing a smaller amount of sodium. The sodium that stays behind gets concentrated in a shrinking blood volume. The result is a sodium level that shoots above normal, which is hypernatremia. Her flushed skin, extreme thirst, reduced urine output, and confusion all fit the hypernatremic picture because high sodium pulls water out of brain cells and stimulates every thirst and water conservation mechanism in the body. Option A, excess sports drink intake, does not match the clinical reality. Sports drinks are designed to roughly replace what sweat takes out and rarely cause hypernatremia on their own during exertion. Option B, acute renal failure, would show up with many other findings like rising creatinine, severe oliguria, and potassium changes, not this clean marathon dehydration pattern. Option C, chronic hyperaldosteronism, builds slowly over months and would present with sustained hypertension, not an acute post-race crash. Here's a D236 OA exam tip for you. Link marathons to hypernatremia using the phrase sweat loses water faster. More water out, more sodium left behind per drop of blood. Marathon equals sweat equals concentration rises equals hypernatremia. Question 12. An elderly patient on long-term furosemide therapy for heart failure presents with new-onset leg cramps, generalized muscle weakness, and occasional cardiac arrhythmias on telemetry monitoring. Which electrolyte disturbance most likely explains this combination of symptoms appearing together in this clinical scenario? A. Hyponatremia from sodium excretion diuretic. B. Hypokalemia from potassium loss diuretic. C. Hypercalcemia from bone reabsorption agent. D. Hypermagnesemia from renal retention impaired.
Do you know the answer?
Correct answer. B. Hypokalemia from potassium loss diuretic. Loop diuretics, like furosemide, cause significant potassium excretion alongside water and sodium loss. The resulting hypokalemia produces classic symptoms of muscle weakness, painful leg cramps, and cardiac arrhythmias through impaired cellular membrane excitability. Option A is incorrect, because while furosemide can cause hyponatremia, low sodium typically presents with headache, nausea, lethargy, and seizures, rather than the muscle cramping and cardiac arrhythmia pattern seen in this patient. Option C is incorrect because hypercalcemia typically causes muscle weakness and constipation, but not leg cramps specifically. Additionally, loop diuretics promote calcium excretion rather than retention, making hypercalcemia an unlikely diagnosis in this clinical scenario. Option D is incorrect because hypermagnesemia would only occur with significant renal impairment and typically causes hyperflexia and hypotension. Loop diuretics generally lower magnesium levels rather than raise them, making this combination unlikely. Furosemide is a loop diuretic, and its side effect signature on potassium is one of the most testable facts in pathophysiology. Loop diuretics work at the thick ascending limb of the loop of Henle, where they block sodium reabsorption. That sounds like a sodium problem, but there is a downstream consequence. Because extra sodium now reaches the distal tubule, the body trades that sodium for potassium and dumps the potassium into urine. Over months of daily furosemide, this potassium loss adds up. The result is hypokalemia, and the clinical picture looks exactly like this patient. Muscle weakness comes from potassium's role in making muscle cells fire. Leg cramps show up because low potassium disrupts calcium handling inside muscle fibers. Cardiac arrhythmias appear because the heart's electrical cells need potassium to repolarize cleanly between beats. Option A, hyponatremia, is possible on diuretics, but would bring headache, lethargy, nausea, and seizures rather than this specific muscle plus rhythm combination. DY undonation. Option C, hypercalcemia, does not fit because loop diuretics cause calcium loss, not retention, and would not explain cardiac arrhythmias plus leg cramps together. Option D, hypermagnesemia, runs the wrong direction because loop diuretics waste magnesium through urine, like they waste potassium. Here's a WGU D236 OA exam tip for you. Remember furosemide as fur loses potassium. Starts with F, like furosemide, ends with loses, K fur loses K, equals hypokalemia, equals cramps and arrhythmias. Question 13. A patient with end-stage renal disease missed 2 consecutive dialysis sessions and arrives at the emergency department with an irregular heartbeat. The cardiac monitor shows tall peaked T waves and a widened QRS complex pattern diode. Which intervention would most likely appear on his treatment plan? A. Insulin with glucose to shift potassium. B. Oral potassium replacement through supplement tablets. C. Normal cell and bolus for fluid resuscitation. D. Calcium gluconate to boost serum calcium.
Do you know the answer?
Correct answer. A. Insulin with glucose to shift potassium. Severe hyperkalemia from missed dialysis causes life-threatening cardiac changes like peaked T waves and widened QRS. Insulin with glucose drives potassium back into cells rapidly, stabilizing cardiac membranes while more definitive dialysis treatment gets arranged. Option B is incorrect because oral potassium replacement would worsen the already dangerously elevated serum potassium levels. This intervention addresses hypokalemia, the opposite problem, and would accelerate this patient's cardiac deterioration rather than help it. Option C is incorrect because normal saline bolus does not address potassium levels directly and could worsen volume overload in a patient with end-stage renal disease who cannot eliminate excess fluid through normal urinary output. Option D is incorrect because calcium gluconate does stabilize cardiac membranes during severe hyperkalemia, but its purpose is membrane stabilization rather than raising serum calcium. The answer framing about boosting calcium misrepresents the intervention's actual clinical purpose. Missed dialysis with peaked T waves and widened QRS is a textbook hyperkalemia emergency, and the treatment chain has a specific order. The heart's electrical cells depend on potassium moving in and out across membranes. When serum potassium climbs too high, those membranes cannot repolarize properly, producing the tall tented T waves and the wide QRS we see on the monitor. If nothing changes quickly, this rhythm slides into ventricular fibrillation or a systole. Insulin with glucose is the fastest intracellular potassium shifter we have. Insulin drives potassium into cells within 30 minutes or so, lowering serum levels enough to stabilize the heart while dialysis gets set up. The glucose goes along for the ride to prevent hypoglycemia from the insulin dose. Option B is dangerous here because oral potassium replacement would raise an already lethal level. You only give potassium when the body is low, not when it is dangerously high. Option C, a normal saline bolus, does nothing for potassium and risks worsening volume overload in a patient whose kidneys are not working. Option D, calcium gluconate, is actually a real part of hyperkalemia treatment, but its role is to stabilize cardiac membranes rather than boost calcium levels. The wording in the answer misrepresents its purpose. Here's a D236 OA exam tip for you. Memorize the hyperkalemia shift move as insulin drives K into cells. Insulin is the K taxi driver. Tells K where to go, takes it home. Insulin drives K equals quick K drop ... Question 14. A postoperative thyroidectomy patient develops facial twitching when her cheek is tapped, along with carpal spasms when a blood pressure cuff is inflated on her arm. Which pathophysiological finding best explains these specific neuromuscular signs appearing together after her surgical procedure? A. Elevated sodium disrupting nerve conduction velocity. B. Reduced magnesium causing generalized smooth muscle. C. Decreased calcium from parathyroid gland damage. D. Increased potassium enhancing neuromuscular excitability thresholds.
What do you think is the answer?
Correct answer, C. Decreased calcium from parathyroid gland damage. Thyroidectomy can accidentally damage nearby parathyroid glands, causing hypocalcemia. Hydrostatic sign with facial tapping and trousseau sign with blood pressure cuff inflation are classic neuromuscular findings from low calcium affecting nerve excitability. Option A is incorrect, because sodium imbalances produce altered mental status, seizures, and confusion, rather than the specific facial and carpal twitch patterns described. Sodium does not cause Hydrostatic's or trousseau's signs clinically. Option B is incorrect, because while hypomagnesemia can mimic hypocalcemia symptoms, the specific link between recent thyroidectomy surgery and parathyroid gland damage points directly toward calcium as the primary electrolyte affected postoperatively here. Option D is incorrect because hyperkalemia typically causes muscle weakness and cardiac arrhythmias, rather than the focal neuromuscular hyperexcitability signs described. Elevated potassium depresses rather than enhances neuromuscular function at higher concentrations. Post-thyroidectomy twitching tells you the surgery nicked something it should not have. The parathyroid glands sit right on the back of the thyroid, 4 small nodes that control calcium balance for the entire body. When a surgeon removes the thyroid, these little glands can get bruised, disrupted, or accidentally taken out with the specimen. Without parathyroid hormone, the kidneys stop reabsorbing calcium properly, and calcium levels drop. Low calcium makes nerves hyperexcitable, which produces the 2 signs we see here. Hydrostatic sign is the facial twitch when you tap near the parotid area, and trousseau's sign is the carpal spasm when a blood pressure cuff stays inflated. Both appear when ionized calcium is low enough to make peripheral nerves fire on their own. Option A is wrong, because sodium imbalances cause seizures, confusion, and mental status changes rather than focal neuromuscular tetany. Option B is close, because magnesium imbalance can mimic hypocalcemia, but the specific thyroidectomy context points directly at the parathyroid glands and their calcium control pathway. Option D is wrong because hyperkalemia causes muscle weakness and cardiac arrhythmias, not twitching or spasms, since high potassium depresses rather than excites neuromuscular junctions. Here's a Wagyu D236 OA exam tip for you. Connect thyroid surgery to calcium using the phrase, thyroid out, parathyroids hurt. Calcium crashes, nerves go crazy. Hydrostatic on the cheek, trousseau in the trap cuff. Thyroid out, calcium down, twitching up. Question 15. A patient with advanced renal failure receives multiple doses of magnesium-containing antacids for gastric discomfort over several days. She begins showing muscle weakness, diminished reflexes, and low blood pressure on routine nursing assessment. Which electrolyte disturbance best explains her new clinical presentation? A. Hypokalemia from gastrointestinal losses continuing chronic. B. Hypermagnesemia from impaired renal excretion. C. Hyponatremia from third spacing fluid shifts. D. Hypocalcemia from vitamin D deficiency.
Can you guess the answer?
Correct answer. B. Hypermagnesemia from impaired renal excretion. Patients with renal failure cannot excrete magnesium normally. When they take magnesium-containing antacids, levels accumulate rapidly. This causes the classic hypermagnesemia triad of muscle weakness, hyperreflexia, and hypotension seen in this patient's presentation. Option A is incorrect, because hypokalemia typically presents with muscle cramping, arrhythmias, and hyperreflexia rather than the diminished reflex pattern seen here. Additionally, there is no gastrointestinal loss history described in this clinical scenario. Option C is incorrect, because hyponatremia usually produces headache, confusion, nausea, and potentially seizures rather than the specific neuromuscular depression pattern described. Third spacing does not clearly fit this clinical presentation either. Option D is incorrect, because hypocalcemia causes hyperexcitability with tetany and twitching rather than diminished reflexes and muscle weakness. Vitamin D deficiency would not explain the acute presentation following recent antacid administration specifically. This patient has two problems colliding. Her kidneys cannot dump magnesium normally, and someone keeps giving her magnesium-containing antacids. The kidneys are the main exit route for magnesium. In healthy people, extra magnesium from food or medicine gets filtered out through urine without a second thought. In advanced renal failure, that exit door is stuck shut. Every dose of magnesium hydroxide or magnesium trisilicate she swallows gets absorbed in the gut, enters circulation, and stays there because her kidneys cannot clear it. Over a few days, magnesium levels climb into the danger zone. Hypermagnesemia acts like a natural calcium channel blocker on neuromuscular tissue. That is why the triad shows up. Muscle weakness, because neuromuscular transmission slows down. Diminished reflexes, because spinal reflex arcs lose their signal strength. Hypotension, because smooth muscle and vessels relaxes and pressure drops. Option A, hypokalemia, does not fit the story because there is no mention of vomiting, diarrhea, or diuretics to explain potassium loss. Option C, hyponatremia, would cause confusion and seizures rather than the specific neuromuscular slowdown pattern seen here. Option D, hypocalcemia from vitamin D deficiency, would cause the opposite picture with hyperexcitable muscles and tetany instead of weakness with diminished reflexes. Here's a D236 OA exam tip for you. Remember the magnesium rule using the phrase, mag makes you mellow. High magnesium mellows everything out. Muscles weaker, reflexes slower, blood pressure lower. Mag mellows equals weak, slow, low. Question 16. A patient with severe CPD arrives at the emergency department with increased confusion, somnolence, and labored breathing. His arterial blood gas shows a pH of 7.28, PCO2 of 58, and HCO3 of 26. Which acid-base disturbance does this specific pattern represent? A. Metabolic alkalosis from prolonged vomiting episodes. B. Metabolic acidosis from diabetic ketoacidosis onset. C. Respiratory alkalosis from anxiety hyperventilation response. D. Respiratory acidosis from CO2 retention uncompensated.
Can you guess the answer?
Correct answer, D. Respiratory acidosis from CO2 retention uncompensated. COPD patients retain CO2 because Damaged lungs cannot exhale enough carbon dioxide. The low pH, with high PCO2, and near normal HCO3 confirms uncompensated respiratory acidosis. Kidneys have not yet started raising bicarbonate for compensation effectively. Option A is incorrect, because metabolic alkalosis would show elevated pH above 7.45 with elevated HCO3 from acid loss. This patient's pH is acidotic at 7.28, ruling out alkalotic patterns from vomiting or similar causes. Option B is incorrect, because metabolic acidosis from DTA would show low HCO3 from bicarbonate consumption by keto acids. This patient's HCO3 remains near normal at 26, pointing toward a respiratory rather than metabolic origin. Option C is incorrect, because respiratory alkalosis would show elevated pH with low PCO2 from hyperventilation blowing off CO2. This patient shows the opposite pattern with low pH and elevated PCO2 from retention instead. COPD blood gas interpretation sits at the core of respiratory pathophysiology, and this pattern has a clean explanation. A pH of 7.28 is below the normal range of 7.35 to 7.45, so the patient is acidotic. To figure out which system caused the acid, look at PCO2 and HCO3 together. His PCO2 is 58, well above the normal 35 to 45, which means carbon dioxide is piling up in his blood. His HCO3 is 26, which sits near the normal ceiling of 22 to 26. When CO2 is high, pH is low, and bicarbonate has not risen to compensate. The picture is respiratory acidosis that is still uncompensated. In COPD, damaged airways and destroyed alveoli make exhaling CO2 harder and harder. CO2 acts like an acid when it mixes with water in the blood, forming carbonic acid. More CO2 equals more acid equals lower pH. Given enough time, the kidneys would start pulling back extra bicarbonate to buffer the acid. But his HCO3 has not climbed yet, so this is an acute or uncompensated state. Option A is wrong, because metabolic alkalosis would show elevated pH above 7.45 with elevated HCO3, not this acidotic pattern. Option B is wrong, because DTA would show low HCO3 from ketoacids eating up bicarbonate reserves, not the near normal HCO3 we see here. Option C is wrong, because respiratory alkalosis needs high pH and low CO2 from hyperventilation, the exact opposite of this patient. Opposite of this patient. Here's a D236 OA exam tip for you. When pH and CO2 move in opposite directions, think respiratory. Low pH plus high CO2 equals respiratory acidosis. Rome equals respiratory opposite, metabolic equal. Pick Rome to pick the winner. Question 17. A newly diagnosed type 1 diabetic arrives with rapid deep breathing, fruity breath odor, and altered mental status. His blood glucose reads 480 mg/dL with positive urine ketones. Which compensatory mechanism explains the distinctive breathing pattern he is demonstrating right now? A. Rapid deep breathing to exhale CO2. B. Slow shallow breathing to retain acids. C. Normal breathing since compensation is unnecessary. D. Irregular apneic pauses from brainstem suppression.
Can you guess the answer?
Correct answer. A. Rapid deep breathing to exhale CO2. Diabetic ketoacidosis creates metabolic acidosis from ketoacid buildup. The lungs compensate through small respirations, which are rapid deep breaths that blow off CO2 rapidly. This attempts to raise pH back toward normal levels quickly. Option B is incorrect, because slow shallow breathing retains CO2 and would worsen the acidosis rather than help it. This breathing pattern actually compensates for metabolic alkalosis, which is the opposite acid-base problem entirely. Option C is incorrect, because severe acidosis always triggers compensation through respiratory changes. The dramatic small breathing pattern described is itself proof that compensation is actively happening rather than being absent during this acute presentation. Option D is incorrect because irregular apneic breathing patterns suggest brainstem injury or opioid overdose rather than metabolic acidosis compensation. DKA produces organized hyperventilation rather than erratic or suppressed respiratory patterns clinically. Small respirations are the body's way of screaming for help in diabetic ketoacidosis, and the mechanism is pure compensation. When insulin is missing, cells cannot use glucose for fuel. The body switches to burning fat, which produces ketone bodies as a byproduct. Some of those ketones are strong acids like beta-hydroxybutyrate and acetoacetate. They pile up in the blood, drop the pH, and create metabolic acidosis. The lungs notice the acid load almost immediately and kick into overdrive. Rapid deep breathing blows off large amounts of CO2, which shifts the carbonic acid equation backwards and lowers the acid burden in the blood. That is small respirations. The fruity breath odor comes from exhaled adetone, another ketone, and confirms the diagnosis at the bedside. Option B is backwards because slow, shallow breathing would retain CO2 and worsen the acidosis, which is what you see with metabolic alkalosis compensation instead. Option C is wrong because severe acidosis always triggers compensation. The dramatic breathing pattern itself is evidence that the compensation mechanism is active rather than absent. Option D is wrong because apneic pauses suggest brainstem injury or opioid overdose, not DKA. DKA produces organized, fast, deep breathing, not erratic breathing. Here's a D236 OA exam tip for you. Tie small breathing to acid removal using the phrase blow off the acid. Lungs blow CO2 out. D2 out. Less CO2 equals less carbonic acid equals pH rises toward normal. Small equals blow off acid. Question 18. A nursing instructor reviews arterial blood gas interpretation with her clinical group before they practice with actual patient data. She asks the students to identify the correct normal reference ranges for the key parameters. Which set of values represents the standard ranges? APS 725 to 735, PC 255 to 65. BPH 745 to 7.55, PCO2 25 to 35. CPS 735 to 7.45, PCO2 35 to 45. DPAX 73 to 7.5, PCO2 40 to 60.
Do you know the answer?
Correct answer. CPS 735 to 745, PCO2 35 to 45. Normal arterial blood gas ranges include pH 7.35 to 745, PCO2 35 to 45 mmHg, and HCO 326 mmHg, LL. These values form the foundation for identifying any acid-base imbalance accurately. Option A is incorrect, because this range is entirely acidotic for pH and shows elevated PCO2, consistent with respiratory acidosis rather than normal physiology. These would never be considered normal reference values in any clinical laboratory. Option B is incorrect because this range is alkalotic for pH and shows decreased PCO2, consistent with respiratory alkalosis. Healthy individuals maintain values closer to neutral rather than at the elevated end of the scale. Option D is incorrect because this range is too wide for both parameters to serve as useful clinical reference values. Actual normal ranges are tighter and more precise than this spread allows for proper acid-base interpretation clinically. Memorizing normal ABG reference ranges is non-negotiable for any nursing exam, and option C is the textbook answer. 3 numbers matter for every arterial blood gas. First, pH runs from 735 to 7.45. Anything below 735 is acidosis, and anything above 745 is alkalosis. Second, PCO2 runs from 35 to 45 millimeters of mercury. This reflects how well the lungs are dumping carbon dioxide. Third, HCO3 runs from 22 to 26 milliequivalents per liter, representing the kidney's metabolic buffer. These 3 values form a triangle that every acid-base interpretation starts from. If any of them is off, You match the direction of the change with pH to figure out whether the cause is respiratory or metabolic. Option A lists a pH range that is entirely acidotic and a pCO2 range that suggests retention, which describes respiratory acidosis rather than normal physiology. Option B shows an alkalotic pH paired with low pCO2, which matches respiratory alkalosis rather than baseline health. Option D uses a range too wide to be clinically useful. Real reference ranges are tight enough to flag small imbalances before patients get sick. Here's a D236 OA exam tip for you. Burn the normal ranges into memory with the phrase pH 35 to 45, CO2 35, CO2 35, bicarb 22 to 26. The first two share the same numbers, which makes the pattern easy. Two sets of 35 to 45 plus 22 to 26. Same numbers, different units, easy recall. Question 19. A young woman in the emergency department after a panic attack shows rapid shallow breathing, tingling around her lips, and carpal spasms. Her arterial blood gas reveals pH 7.52 and pCO2 of 28. All. Which acid-base pattern does this specific clinical scenario represent? A. Metabolic alkalosis, secondary to vomiting episodes. B. Metabolic acidosis from lactic acid accumulation. C. Respiratory acidosis from oversedation after medication. D. Respiratory alkalosis from hyperventilation blowing.
What do you think is the answer?
Correct answer. D. Respiratory alkalosis from hyperventilation blowing. Panic attacks cause hyperventilation, which exhales excess CO2 rapidly. This raises pH above normal, creating respiratory alkalosis. The tingling and carpal spasms occur because alkalosis lowers ionized calcium, producing neuromuscular irritability symptoms in her extremities. Option A is incorrect because metabolic alkalosis from vomiting would show elevated HCO3 as the primary driver rather than decreased pCO2. This patient's low pCO2 clearly points toward a respiratory rather than metabolic cause for her alkalosis. Option B is incorrect because metabolic acidosis produces low pH below 7.35 rather than elevated pH of 7.52. Lactic acidosis would drive the patient's acid-base chemistry in the opposite direction from what her lab values actually show. Option C is incorrect because respiratory acidosis from oversedation would show elevated pCO2 and low pH from retained CO2. This patient's low pCO2 of 28 and high pH rule out respiratory depression as the underlying cause here. Panic attack blood gases reveal a clean respiratory alkalosis pattern, and the tingling gives the diagnosis away before you even see the numbers. During a panic attack, the woman's breathing rate shoots up without her choosing it. Rapid shallow breathing blows off CO2 faster than the body makes it. Less CO2 in the blood means less carbonic acid, which pushes pH upward above normal. Her values confirm this. A pH of 7.52 is above the top of 7.45, so she is alkalotic. So a pCO2 of 28 is below the bottom of 35, confirming she has exhaled too much CO2. Because pH and CO2 moved in opposite directions, we call this respiratory. Alkalosis lowers ionized calcium by pulling it onto albumin, which leaves less free calcium available for nerves and muscles. That is what produces the tingling around her lips and the carpal spasms in her hands. Option A, metabolic alkalosis from vomiting, would show elevated HCO3 as the main driver rather than this low pCO2 pattern. Option B, metabolic acidosis, would show low pH, not this high pH. Option C, respiratory acidosis from oversedation, would show high pCO2 and low pH, both opposite to the number she has. Here's a D236 OA exam tip for you. When you see panic attack, plus tingling fingers plus carpal spasm, think blow off too much. Blow off CO2, blow off acid, pH climbs, calcium drops, nerves fire. Panic equals hyperventilation equals respiratory alkalosis. Question 20. A patient with severe bulimia nervosa has been engaging in daily self-induced vomiting episodes for several weeks. She arrives at her primary care appointment with muscle weakness, confusion, and abnormal lab values. Which acid-base disturbance most likely appears on her arterial blood gas results? A. Respiratory acidosis from shallow breathing compensating. B. Metabolic alkalosis from hydrogen ion losses. C. Respiratory alkalosis from hyperventilation during vomiting. D. Metabolic acidosis from diarrhea and dehydration.
What do you think is the answer?
Correct answer. B. Metabolic alkalosis from hydrogen ion losses. Chronic vomiting removes large amounts of hydrochloric acid from the stomach. This loss of hydrogen ions raises blood pH above normal, creating metabolic alkalosis. Accompanying hypokalemia worsens her muscle weakness and cognitive changes clinically. Option A is incorrect because respiratory acidosis involves CO2 retention from hypoventilation rather than any vomiting-related mechanism, while her lungs may compensate by slowing respiration slightly. The primary disturbance remains metabolic rather than respiratory in origin. Option C is incorrect because respiratory alkalosis requires sustained hyperventilation rather than transient breathing changes during vomiting episodes. The consistent pattern of acid loss from stomach contents drives this patient's alkalotic state more powerfully. Option D is incorrect because metabolic acidosis from diarrhea involves bicarbonate losses from the intestines rather than hydrogen ion losses from the stomach. The mechanism and resulting pH changes move in opposite directions between these two conditions. Bulimia's acid-base twist comes straight from the stomach. When she vomits repeatedly, she is not just losing food. She is losing hydrochloric acid, which the stomach produces in large amounts to aid digestion. Every time she vomits, she throws out hydrogen ions along with chloride. The body runs low on hydrogen, which is the core ingredient of acid. Losing acid directly raises blood pH, and that is the definition of metabolic alkalosis. On top of that, she loses potassium through her kidneys as they try to hold on to sodium, producing the hypokalemia that fuels her muscle weakness. The combined picture of alkalotic pH, low potassium, confusion, and weakness fits the bulimia pattern exactly. Option A, respiratory acidosis, does not match because there is nothing about shallow breathing or retained CO2 in her story. Her lungs might actually slow down slightly to retain some CO2 as compensation, but the primary disturbance is still metabolic. Option C, respiratory alkalosis, fails because panic-style hyperventilation is not what drives the acid-base shift here. The stomach is the source, not the lungs. Option D, metabolic acidosis from diarrhea, runs the wrong direction because diarrhea loses bicarbonate from the lower GI tract, which causes acidosis, not alkalosis. Vomiting loses acid, diarrhea loses base. Here's a WGD D236 OA exam tip for you. When you see vomiting repeatedly plus weakness, think throw up acid equals alkalosis. Stomach makes HCl. Throwing up HCl means losing acid. Less acid equals higher pH dye. Vomit equals alkalosis. Diarrhea equals acidosis. Opposite ends, opposite results. Question 21. A genetics professor explains to her students how some cancers develop from a combination of inherited and acquired mutations, rather than from a single genetic change alone, which best describes the core concept behind Knutson's two-hit hypothesis for cancer development. A. Both alleles of a gene require mutation. B. One damaged allele alone triggers cancer immediately. C. Environmental exposure alone causes all inherited cancers. D. The chromosomal translocation must precede any genetic mutation.
Can you guess the answer?
Correct answer. A. Both alleles of a gene require mutation. Knutson's hypothesis states that most hereditary cancers need two separate mutational events, one affecting each allele. The first hit may be inherited or acquired, and the second hit completes the damage that allows cancer to develop. Option B is incorrect, because one damaged allele typically gets compensated by the healthy corresponding allele. Cancer development usually requires the second hit to disable the remaining functional copy before malignant transformation begins in cells. Option C is incorrect, because environmental exposure alone explains some acquired mutations, but not the core hypothesis. Knudson specifically described the combination of genetic predisposition plus additional mutations rather than environmental causes in isolation entirely. Option D is incorrect because chromosomal translocation represents one specific type of mutation among many possibilities. Knutson's hypothesis addresses mutational events broadly rather than requiring translocation specifically as the mechanism for genetic damage. Knutson's two-hit hypothesis is one of those ideas that sounds complex but clicks once you picture it. Alfred Knudson studied retinoblastoma and noticed something strange. Hereditary cases showed up earlier and in both eyes, while sporadic cases appeared later and in one eye. That pattern told him a single genetic change was not enough to cause cancer on its own. His hypothesis said that certain cancers need two separate hits on the same gene, one on each allele. Most of our genes come in pairs, one from mom and one from dad. As long as one healthy copy still works, the cell usually behaves normally. Cancer develops when both copies get damaged, leaving no backup to control cell growth. The first hit can be inherited through the germline or acquired during life. The second hit almost always comes from something acquired like radiation, chemicals, or random replication errors. Option B misses, because one damaged allele usually gets covered by the healthy partner. Option C is too narrow, because environmental exposure alone ignores the inherited piece Knudson was trying to explain. Option D fixates on translocation, which is just one type of mutation among many the hypothesis covers. Here's a Wagyu D236 OA exam tip for you. Remember Knudson as two hits, two copies down. Both alleles have to fail before cancer starts. Two hits means two KS knocked out. Two copies out, cancer on. Question 22. A 3-year-old presents with bilateral retinoblastoma, and her genetic workup reveals an inherited mutation in the R-bone gene. Her oncologist explains why hereditary cases differ from sporadic ones clinically. Which pattern distinguishes hereditary from non-hereditary retinoblastoma presentations in pediatric patients? A. Hereditary affects adults only later in life. B. Sporadic cases always show bilateral eye involvement. C. Hereditary presents earlier and often bilaterally. D. Sporadic cases require two inherited gene mutations.
Can you guess the answer?
Correct answer. C. Hereditary presents earlier and often bilaterally. Hereditary retinoblastoma appears in younger children and frequently affects both eyes because the first hit is already present at birth. Only one additional mutation is needed anywhere to trigger cancer, increasing probability of bilateral disease significantly. Option A is incorrect, because hereditary retinoblastoma actually presents in young children rather than adults. The inherited first hit allows the cancer to develop much earlier than sporadic forms, making childhood presentation the expected pattern clinically. Option B is incorrect, because sporadic cases typically involve only one eye since two separate mutations must occur in the same cell. Bilateral presentation would require this rare coincidence in both eyes, making unilateral disease far more common sporadically. Option D is incorrect, because sporadic cases involve two acquired mutations rather than inherited ones. The defining feature of sporadic retinoblastoma is that neither mutation comes from the parents through germline transmission to offspring genetically. Hereditary retinoblastoma gives us the perfect window into how two-hit genetics plays out in real children. In the hereditary form, a child is born with one bad copy of the RBONE gene already present in every cell of the body. That means the first hit is done from day one. Only one more mutation anywhere in a retinal cell is enough to trigger cancer. Because every retinal cell is already halfway there, the odds of a second hit hitting at least one cell, sometimes in both eyes, rise dramatically. That is why hereditary retinoblastoma shows up earlier in life and often appears bilaterally. Sporadic retinoblastoma works differently. Children with this form are born with two healthy RBONE alleles. For cancer to form, two separate mutations must hit the same retinal cell. That double event is rare, so sporadic cases are usually later onset and almost always affect only one eye. Option A is wrong, because hereditary retinoblastoma appears in young children, not adults. Option B is wrong, because sporadic cases typically involve only one eye. Option D is wrong, because sporadic cases involve acquired rather than inherited mutations. Here's a D236 OA exam tip for you. Link hereditary retinoblastoma to bilateral disease using born with one hit. Born with a head start means faster, more widespread cancer. Born with one hit equals earlier plus both eyes. Question 23. A patient with a strong family history of breast cancer tests, positive for a BRCA1 mutation, but has no current signs of malignancy herself. Her oncologist explains why she has elevated risk, but has not developed cancer yet. Which explanation fits the two-hit framework best? A. The inherited mutation completes cancer development alone. B. She carries one damaged allele requiring second mutation. C. BRCA mutations skip generations and become inactive. D. Environmental toxins override all inherited genetic mutations completely.
Do you know the answer?
Correct answer, B. She carries one damaged allele requiring second mutation. BRCA1 mutation carriers inherit one damaged allele as their first hit. The healthy corresponding allele still works until a second mutation disables it, which is why carriers have elevated risk but may not develop cancer immediately. Option A is incorrect because the inherited mutation alone does not complete cancer development in the two-hit model. The healthy remaining allele compensates until it also becomes damaged through additional mutational events acquired during the carrier's lifetime. Option C is incorrect because BRCA mutations do not become inactive or skip generations in the manner described. These mutations follow standard autosomal dominant inheritance patterns and maintain their disease predisposing effect throughout each generation of carriers. Option D is incorrect because environmental toxins may contribute to second-hit mutations, but do not override inherited genetic changes entirely. The combination of inherited predisposition plus environmental exposure fits the two-hit model rather than replacing it. BRCA1 carriers raise a fair question. If the mutation is already there, why has cancer not started yet? The answer lives in the two-hit model. A BRCA1 carrier inherits one damaged allele from a parent. That is the first hit, present in every cell of the body from conception. But her other BRCA1 allele, the one she got from her other parent, is still healthy and still works. Tumor suppressor genes like BRCA1 only stop protecting the cell when both copies fail. So as long as the healthy allele keeps doing its job, cells behave normally. Her elevated cancer risk comes from the fact that the other shoe can drop at any time. A single additional mutation in her remaining BRCA1 allele, caused by radiation, chemicals, or random replication mistakes, would finish the job and allow cancer to develop. Until that second hit happens, she is a carrier, not a patient. Option A is wrong because one inherited mutation does not complete cancer in the two-hit framework. Option C is wrong because BRCA mutations follow autosomal dominant inheritance and do not skip generations in that way. Option D is wrong because environmental toxins add to risk rather than override the inherited component. Here's a D236 OA exam tip for you. Picture B or CA carriers as one copy down, one to go. She started the race with one flat tire. Hit the second tire, and the car stops. One copy down equals risk rises. Cancer waits. Question 24. A patient with familial adenomatous polyposis develops hundreds of colon polyps by his early 20s, despite having only one mutated copy of the APC gene inherited from his father. His gastroenterologist explains why this disease breaks the typical two-hit rule. Which explanation fits? A. FAP requires two inherited alleles to manifest. B. FAP is actually a recessive condition clinically. C. FAP skips the two-hit rule through environmental triggers. D. FAP is autosomal dominant needing one mutation.
What do you think is the answer?
Correct answer. D. FAP is autosomal dominant needing one mutation. Familial adenomatous polyposis is autosomal dominant, meaning one mutated allele alone causes the disease to manifest. This breaks the standard two-hit rule because the single inherited mutation is sufficient to trigger polyp formation without additional damage. Option A is incorrect because FAP requires only one mutated allele rather than two. This single allele requirement is exactly what distinguishes autosomal dominant conditions from autosomal recessive ones and from standard two-hit cancer genetics entirely. Option B is incorrect because FAP follows autosomal dominant rather than recessive inheritance patterns. In autosomal dominant conditions, only one parent needs to pass down the affected gene for the child to show the disease clinically. Option C is incorrect because FAP does not involve environmental triggers to bypass the two-hit rule. The disease mechanism stems purely from the dominant nature of the APC mutation rather than from acquired environmental mutations in cells. FAP is the exception that proves the rule in cancer genetics. Familial adenomatous polyposis follows autosomal dominant inheritance, which means one damaged copy of the APC gene is enough to cause the disease. He inherited that single mutation from his father, and it shows up in every cell of his colon. Because APC works as a dominant acting tumor control gene in this context, the one mutated allele alone disrupts normal cell growth regulation. That is why patients with FAP develop hundreds or even thousands of polyps in the colon by their 20s. Any one of those polyps can later pick up additional mutations and turn malignant, which is why colectomy is often recommended before cancer develops. This pattern breaks the classic two-hit rule because the disease manifestation starts with just one hit. The later progression to actual cancer inside specific polyps does follow the two-hit pattern, but the polyp formation itself is dominant. Option A is wrong because FAP needs only one mutated allele. Option B is wrong because FAP follows autosomal dominant rather than recessive rules. Option C is wrong because the single mutation rule comes from the dominant genetic pattern rather than environmental triggers. Here's a D236 OA exam tip for you. Remember FAP using dominant means one is done. Dominant conditions need only one mutated allele to show disease. FAP equals father's APC mutation passed down, one allele, polyps pop up. Question 25. A newborn displays distinctive facial features, hypotonia, and a single palmar crease. Karyotyping reveals 3 copies of chromosome 21 in every cell examined. Which specific mechanism most commonly produces this extra chromosome during the formation of the original fertilized embryo? A. Non-disjunction during meiotic cell division. B. Translocation, moving chromosome fragments between chromosomes. C. Chromosomal deletion, losing genetic material portions. D. Point mutation, altering single nucleotide bases.
Can you guess the answer?
Correct answer. A. Non-disjunction during meiotic cell division. Non-disjunction occurs when chromosomes fail to separate properly during meiosis. This produces gametes with extra or missing chromosomes. About 95% of Down syndrome cases result from non-disjunction of chromosome 21 during egg or sperm formation specifically. Option B is incorrect, because translocation accounts for a smaller percentage of Down syndrome cases rather than being the most common cause. In translocation Down syndrome, chromosome 21 material attaches to another chromosome, rather than existing as 3 full copies. Option C is incorrect, because chromosomal deletion involves losing genetic material rather than gaining it. Down syndrome results from an extra chromosome rather than from missing pieces, making deletion the wrong mechanism for this specific trisomy presentation entirely. Option D is incorrect, because point mutations change single nucleotides within a gene rather than affecting whole chromosome numbers. Down syndrome involves an entire extra chromosome rather than small-scale changes at the individual nucleotide base level. Down syndrome and the extra chromosome 21 tell a story about cell division gone wrong at a very specific moment. Normal human cells carry 46 chromosomes arranged in 23 pairs. When eggs and sperm form, they go through meiosis, which cuts the chromosome number in half, so each gamete carries 23. Non-disjunction is what happens when a pair of chromosomes fails to split apart during meiosis. Instead of one chromosome going to each new cell, both chromosomes go to one side and none to the other. That creates one gamete with 24 chromosomes, and another with 22. If the gamete carrying 24 chromosomes fertilizes a normal gamete, the embryo ends up with 3 copies of one chromosome, called trisomy. When this happens to chromosome 21, the result is Down syndrome. Around 95% of Down syndrome cases come from this mechanism. The extra copy drives the distinctive facial features, hypotonia, the single palmar crease, and characteristic developmental profile. Option B is wrong because translocation Down syndrome exists, but accounts for only a small percentage of cases. Option C is wrong because deletion removes material rather than adding it. Option D is wrong because point mutations change single nucleotides rather than chromosome numbers. Here's a WGU D236 OA exam tip for you. Tie Down syndrome to non-disjunction using the phrase chromosomes did not split. Split failure equals extra chromosome equals trisomy 21. Did not split equals double delivery equals Down syndrome. Question 26. A pregnant patient at her first prenatal visit asks the nurse practitioner how much wine is considered safe during pregnancy since her mother drank occasionally without problems. Which response best reflects current evidence-based guidance about alcohol consumption during any stage of pregnancy? A. 1 glass weekly during second trimester is safe. B. Beer contains less alcohol, so remains acceptable daily. C. No amount or type of alcohol is safe. D. Only third trimester drinking poses significant fetal risk.
What do you think is the answer?
Correct answer. C. No amount or type of alcohol is safe. Alcohol crosses the placenta directly to the developing fetus regardless of type. No safe amount or safe time during pregnancy has been established. All forms including wine and beer can cause harm at any stage. Option A is incorrect, because weekly wine consumption during any trimester can cause fetal damage. The second trimester still involves critical brain development and organ formation that alcohol disrupts regardless of the small quantity consumed during pregnancy. Option B is incorrect, because beer contains equivalent alcohol content on a per-drink basis when portion sizes are standard. The myth about beer being safer ignores how alcohol molecules cross the placenta identically regardless of beverage source. Option D is incorrect, because alcohol damage can occur during any trimester, including the earliest weeks before pregnancy recognition. Organ and brain development happen throughout gestation, making no trimester genuinely safe for maternal alcohol consumption during pregnancy. The safe alcohol during pregnancy question has one honest answer, and that answer is none. Alcohol is a small molecule that crosses the placenta freely. Whatever mom drinks, the fetus gets the same concentration in their bloodstream within minutes. The fetal liver is underdeveloped, so the baby cannot break alcohol down as efficiently as an adult. That means even a small amount mom drinks stays in fetal circulation longer. No study has ever found a safe threshold. The CDC, the American College of Obstetricians and Gynecologists, and every major professional group agree that no amount, no type, and no trimester is safe. The mother's statement that her own mother drank without problems reflects one of the toughest realities about fetal alcohol damage. Some babies seem to escape obvious damage, while others sustain severe harm from similar exposures. Individual fetal vulnerability varies widely, so past luck does not guarantee future safety. Option A is wrong, because weekly wine during any trimester still poses risk. Option B is wrong because alcohol crosses the placenta, the same way whether it came from beer, wine, or spirits. Option D is wrong because damage can happen at any trimester, including the earliest weeks. Here's a D236 OA exam tip for you. Link the answer to the phrase 0 alcohol, 0 trimester. No amount, no type, no stage is proven safe. 0 is 0. When in doubt, 0 wins tight. Question 27. A developmental pediatrician evaluates a 5-year-old with smooth philtrum, growth below 3rd percentile, and significant learning delays affecting school performance. His mother reports heavy drinking throughout pregnancy. Which specific diagnosis along the FASD spectrum best matches this clinical picture? A. Alcohol-related neurodevelopmental disorder only. B. Partial fetal alcohol syndrome with minimal features. C. Alcohol-related birth defects without facial involvement. D. Fetal alcohol syndrome with full clinical presentation.
What do you think is the answer?
Correct answer, D. Fetal alcohol syndrome with full clinical presentation. Fetal alcohol syndrome is the most severe form, requiring central nervous system problems, growth impairment, and distinctive facial features like smooth philtrum. This child shows all 3 diagnostic criteria, placing the diagnosis clearly within full FAS territory. Option A is incorrect, because ARND primarily affects intellectual abilities and behavior, without the physical growth failure and distinctive facial features seen here. This child's complete symptom profile extends beyond the ARND diagnostic boundaries, specifically. Option B is incorrect because partial FAS shows fewer symptoms than the full syndrome. This child demonstrates the full triad of facial features, growth impairment, and CNS involvement, rather than the more limited partial presentation. Option C is incorrect because alcohol-related birth defects focus primarily on physical abnormalities like heart, kidney, or bone defects, rather than the facial and growth features described here. The presentation better matches full FAS criteria specifically. Fetal alcohol syndrome has a specific diagnostic triad, and this child hits every piece of it. FAS is the most severe end of the fetal alcohol spectrum disorders, or FAS-ASD family. To diagnose full FAS, clinicians look for 3 things together. First, central nervous system involvement, which shows up as learning delays, intellectual disability, or behavior problems. Second, growth impairment, typically defined as height or weight below the 10th percentile. Third, a set of distinctive facial features including a smooth philtrum, thin upper lip, and small palpebral fissures. This 5-year-old shows growth below the 3rd percentile, significant learning delays, and a smooth philtrum. That checks every box for full fetal alcohol syndrome. His mother's confirmed history of heavy drinking during pregnancy completes the clinical picture. Option A, ARND, covers children with cognitive and behavioral problems from prenatal alcohol exposure, but who lack the physical markers. This child has the facial features, so ARND is too mild a label. Option B, partial S, applies when some but not all features appear. This child has all 3, so partial is also too mild. Option C, alcohol-related birth defects, describes heart, kidney, or bone malformations rather than the facial plus growth plus CNS combination seen here. Here's a D236 OA exam tip for you. Remember, full FS is face plus size plus brain. 3 boxes checked equals full FAS. Face, ACE, filtrum, tanta. Size AG growth, impaired. Brain sub-E learning delays. 3 Fs, full FAS. Question 28. A college student at 6 weeks pregnant realizes she drank heavily at several parties before discovering her pregnancy. She asks whether the early exposure matters since she was unaware. Which response best explains the critical timing concern regarding prenatal alcohol exposure and fetal development? A. Damage can occur before pregnancy awareness. B. Only exposure after 8 weeks causes problems. C. First trimester drinking rarely causes any defects. D. Early exposure produces only minor cognitive delays.
What do you think is the answer?
Correct answer. A. Damage can occur before pregnancy awareness. Alcohol can harm the fetus as early as 4 to 6 weeks into pregnancy, often before women know they are pregnant. Critical organ formation and neural development begin immediately after conception, making early exposure particularly damaging despite lack of awareness. Option B is incorrect. Because alcohol damage starts well before 8 weeks gestation, the neural tube forms and organ systems begin developing during the earliest weeks, when many women do not yet realize they are pregnant clinically. Option C is incorrect because first trimester drinking carries substantial risk for birth defects, particularly facial abnormalities and major organ malformations. This period involves the most intense organogenesis, when cells are most vulnerable to teratogenic exposure. Option D is incorrect because early exposure can produce severe, rather than minor effects. Facial abnormalities and significant cognitive disabilities often trace back to first trimester drinking, making early exposure potentially devastating rather than mild in consequence. Early pregnancy alcohol exposure sits at the heart of this question, and the biology explains why awareness often comes too late. The embryo starts developing organs almost immediately after conception. The neural tube, which becomes the brain and spinal cord, begins forming around week 3 or 4. Heart tissue forms by week 4. Facial structures like the filtrum develop during weeks 5 through 9. Many women do not recognize they are pregnant until week 6 or later, which means heavy drinking at 6 weeks has already overlapped with some of the most sensitive windows for organ formation. Alcohol interferes with cell migration, cell death timing, and the signaling that tells embryonic tissues how to line up correctly. Once a structural defect forms, it cannot be reversed. That is why her question deserves a careful and honest answer. She cannot undo exposure that already happened, but she can stop drinking now and reduce additional risk for the remaining pregnancy. Option B is wrong because major damage happens well before 8 weeks. Option C is wrong because first trimester drinking carries some of the highest risk for birth defects. Option D is wrong because early exposure can produce severe rather than minor effects. Here's a D236 OA exam tip for you. Link early pregnancy exposure to the phrase damage before discovery. The embryo is building while she is still testing pregnancy tests. Damage before discovery means stop now and test later for effects. Question 29. A 14-year-old with prenatal alcohol exposure shows poor impulse control, difficulty with math, problems interpreting social cues, and challenges with daily living tasks but lacks distinctive facial features. Which DSM-5 diagnosis most accurately captures this presentation without requiring the physical markers? A. Attention deficit hyperactivity disorder primary. B. Neurobehavioral disorder associated with prenatal alcohol exposure. C. Full fetal alcohol syndrome with facial features absent. D. Alcohol-related birth defects affecting behavioral regulation.
What do you think is the answer?
Correct answer. B. Neurobehavioral disorder associated with prenatal alcohol exposure. ND-PA was introduced in DSM-5 to capture neurobehavioral effects from prenatal alcohol without requiring physical markers. Diagnosis requires exposure exceeding 13 drinks monthly or 2 drinks in one sitting, along with problems in thinking, behavior, and daily function. Option A is incorrect because ADHD does not require prenatal alcohol exposure history, while symptoms overlap with FASD conditions. The diagnostic framework differs entirely, and the specific alcohol-related etiology distinguishes NDPA from primary attention deficit disorders clinically. Option C is incorrect because full FAS diagnosis requires facial features, including smooth philtrum and small palpebral fissures. This teenager lacks those physical markers, making FAS diagnosis inappropriate despite the clear cognitive and behavioral impacts present. Option D is incorrect because alcohol-related birth defects focus on physical malformations like heart or kidney problems, rather than the behavioral and cognitive pattern described. ARB does not typically capture this specific neurobehavioral symptom cluster accurately. NDPA is the DSM-5's way of capturing alcohol's behavioral damage when the face does not tell the story. Not every child affected by prenatal alcohol exposure grows up with the classic smooth philtrum and thin upper lip. Many sustain neurological harm without the physical markers that let clinicians diagnose full fetal alcohol syndrome. Before the DSM-5, those children often went unrecognized because they did not fit the FAS box. Neurobehavioral disorder associated with prenatal alcohol exposure, or NDPA, fills that gap. The diagnosis requires a documented history of significant prenatal alcohol exposure, defined as more than 13 drinks per month or more than 2 drinks in a single sitting during pregnancy. It also requires neurocognitive impairment in thinking or learning, self-regulation problems in behavior or attention, and difficulty with adaptive functioning or daily life skills. This 14-year-old fits the NDPA pattern. Poor impulse control checks the self-regulation box. Difficulty with math checks, neurocognitive impairment. Trouble reading social cues and managing daily tasks checks adaptive function. No facial features means full FAS does not apply, but NDPA captures his presentation precisely. Option A, ADHD, does not require prenatal alcohol exposure and misses the etiological anchor. Option C, full FAS, requires the distinctive face he does not have. Option D, RBD, describes physical birth defects rather than this behavioral pattern. Here's a D236 OA exam tip for you. Remember NDPA as neurobehavioral, no face. DSM-5 added it for kids with the brain damage minus the physical markers. Brain damage, no face, equals NDPA. Question 30. A multidisciplinary team evaluates a 4-year-old for possible FASD. Which combination of findings would best support the diagnosis beyond requiring confirmation of prenatal alcohol exposure, since many mothers deny drinking or cannot accurately recall their consumption patterns during pregnancy? A. Normal growth with isolated speech delays only. B. Large head circumference with advanced motor skills. C. Full-term delivery with above-average birth weight. D. Small head, growth impairment and facial features.
Can you guess the answer?
Correct answer. D. Small head, growth impairment, and facial features. FAS diagnosis centers on 4 areas including CNS issues like small head size, growth impairment below average, and distinctive facial features such as smooth philtrum. These findings support diagnosis even when maternal alcohol history cannot be verified clinically. Option A is incorrect because isolated speech delays without other markers do not meet SES diagnostic criteria. The syndrome requires multiple affected domains including physical, behavioral, and developmental indicators rather than a single, isolated developmental concern alone. Option B is incorrect because SSD produces small head circumference and delayed motor skills rather than large head or advanced motor development. These findings would actually rule against the diagnosis rather than supporting it clinically during evaluation. Option C is incorrect because full-term delivery with high birth weight argues against FAST rather than supporting it. Growth impairment is a core diagnostic feature, and the described findings represent the opposite of typical FASD presentations. Diagnosing FASD without maternal admission of drinking is a common real-world problem, and the clinical findings have to carry the weight. Mothers often deny drinking during pregnancy because of guilt, stigma, memory gaps, or legal worries. Clinicians cannot rely on a verbal confirmation alone, so FASD diagnostic frameworks include findings that stand on their own regardless of what the mother reports. 3 key findings anchor FASD diagnosis. Small head circumference, known as microcephaly, shows central nervous system damage from alcohol exposure during brain growth. Growth impairment below the 10th percentile for height or weight shows alcohol's impact on overall fetal development. Distinctive facial features, especially a smooth philtrum, thin upper lip, and small palpebral fissures, are specific enough that they rarely occur together outside of alcohol exposure. When a child shows all 3, the diagnosis can be made with or without a confirmed maternal history. This combination is clinically recognizable and highly specific to alcohol teratogenesis. Option A is wrong because isolated speech delays do not meet FASD criteria and can come from many causes. Option B is wrong because FASD produces small head size and delayed motor milestones rather than large head or advanced motor skills. Option C is wrong because full-term delivery with above-average birth weight argues against FASD rather than supporting it. Here's a D236 OA exam tip for you. Memorize the FASD triad as small head, small body, specific face. 3 smalls and 1 specific equals FASD confirmed. Small, small, specific equals diagnosis locked. Dodd. Question 31. A newborn arrives at the emergency department with a respiratory infection. Despite being only 3 days old, her body shows some defense mechanisms actively working against the invading pathogens. Which components represent the innate immunity that was present from birth without prior exposure? A. Barriers, phagocytes, and complement proteins. B. Memory B cells, plasma cells, and antibodies. C. Helper T cells, cytotoxic T cells, and cytokines. D. Immunoglobulin E, allergic responses, and mast cells.
What do you think is the answer?
Correct answer. A. 1. B. Initial. Barriers, phagocytes, and complement proteins. Innate immunity is present from birth and includes physical barriers like skin and mucous membranes, phagocytic cells such as neutrophils and macrophages, and the complement system that destroys pathogens through membrane attack complexes formed on microbial surfaces. Option B is incorrect because memory B cells, plasma cells, and antibodies are components of adaptive immunity rather than innate defenses. These require previous pathogen exposure to develop fully and are not immediately available in newborns without prior antigen encounters. Option C is incorrect because helper T cells, cytotoxic T cells, and cytokines belong to adaptive immunity rather than innate defenses. These specific components develop through pathogen exposure over time and form part of the acquired response system. Option D is incorrect because IgA and mast cell involvement primarily drive allergic responses rather than general innate immunity. While innate, this specific pathway handles hypersensitivity reactions rather than the broader pathogen defense system described. Innate immunity is the defense team you were born with, and a 3-day-old newborn relies on it heavily. Innate immunity is the body's first and fastest responder. It does not need any prior exposure to work. The moment a pathogen shows up, innate defenses kick in within minutes. 3 components do most of the heavy lifting in innate immunity. Physical barriers like the skin, mucous membranes, and stomach acid stop pathogens from entering in the first place. Phagocytes like neutrophils and macrophages patrol tissues and swallow invaders through phagocytosis. The complement system is a set of plasma proteins that tag pathogens for destruction and can punch holes in bacterial membranes directly. All three of these work from birth, no pre-exposure required. A 3-day-old baby still has these tools online, which is exactly why she is fighting the respiratory infection at all. Option B is wrong because memory B cells, plasma cells, and antibodies belong to adaptive immunity. Those cells need previous exposure to develop, and a newborn has barely encountered anything yet. Option C is wrong because helper T cells, cytotoxic T cells, and their cytokines are also adaptive and depend on antigen-driven selection over time. Option D is wrong because IgA and mast cells drive allergic responses rather than general newborn defense against infection. Here's a D236 OA exam tip for you. Remember innate immunity as born before born. The defenses are there before any pathogen ever touched you. Born before born equals barriers, phagocytes, complement. 3 parts, ready from day 1. Die. Question 32. A patient recovering from pneumonia needs her nurse to explain how her body built lasting protection against the specific bacteria. The nurse describes cells that differentiated after the infection to produce antibodies and create long-term memory. Which specific immune cells does this description accurately characterize? A. Natural killer cells attacking infected host cells. B. Macrophages performing phagocytosis at infection sites. C. B cells becoming plasma cells and memory cells. D. Neutrophils responding through rapid diapedesis movement.
Do you know the answer?
Correct answer. C. B cells becoming plasma cells and memory cells. Activated B cells differentiate into plasma cells that produce antibodies against the specific pathogen, and memory B cells that persist long-term. This allows faster, stronger immune responses upon re-exposure to the same bacterium in future infections. Option A is incorrect, because natural killer cells attack virus-infected or cancerous host cells directly rather than producing antibodies. They belong to innate immunity and do not differentiate into antibody-producing or memory-forming cell types described. Option B is incorrect, because macrophages perform phagocytosis and present antigens but do not differentiate into antibody-producing plasma cells. They serve as supporting players in the adaptive response rather than as the primary antibody-generating cell line. Option D is incorrect, because neutrophils are phagocytic cells that respond rapidly through diapedesis, but have short lifespans and do not form memory cells. They serve innate immunity rather than becoming long-term antibody-producing plasma cells, specifically. Antibody-producing memory cells are the finale of the adaptive response, and B cells are the stars of this show. When a new pathogen like pneumonia bacteria enters the body, B cells recognize a specific piece of that bacterium through their surface receptors. Once activated with help from helper T cells, the B cell begins to divide rapidly. Each B cell splits into 2 functional destinies. Some become plasma cells, which turn into antibody factories. Plasma cells pump out huge numbers of specific antibodies into the bloodstream to tag and neutralize the bacteria. Others become memory B cells, which are the long-term records of the infection. Memory B cells live for years or even decades, waiting quietly in lymph tissue. If the same bacteria ever shows up again, memory cells snap into action much faster than the first time, producing larger amounts of antibody in less time. That is why second exposures to the same pathogen usually cause milder illness or no illness at all. Option A is wrong because natural killer cells attack host cells that have been hijacked by viruses or turned cancerous, not bacterial infections with antibody formation. Option B is wrong because macrophages are phagocytes and antigen presenters, not antibody producers themselves. Option D is wrong because neutrophils are short-lived first responders rather than memory-forming cells. Here's a D236 OA exam tip for you. Remember B cells as B equals builds antibody. Plasma cells produce antibodies. Memory cells remember for next time. B builds, P pumps, M remembers. Question 33. A patient with a viral infection needs her immune system to eliminate cells that have already been infected by the virus. Her body activates specific cells that bind to infected cells and destroy them by puncturing their membranes. Which cell type performs this specific function? A. Plasma cells, secreting neutralizing antibodies abundantly. B. Helper T cells producing activating cytokines. CB memory cells, storing antigen information permanently. D. Cytotoxic T cells, puncturing infected cell membranes.
Can you guess the answer?
Correct answer. B. Cytotoxic T cells puncturing infected cell membranes. Cytotoxic T cells recognize and bind to body cells displaying foreign antigens from viral infections. They kill these infected cells directly by puncturing membranes, preventing viral replication and spread through destruction of infected host cells throughout the body. Option A is incorrect, because plasma cells produce antibodies that neutralize free pathogens in circulation, rather than killing infected body cells directly. Their role involves tagging invaders, rather than destroying host cells that carry viral particles internally. Option B is incorrect, because helper T cells produce cytokines to coordinate immune responses but do not directly kill infected cells. Their function centers on activating other immune cells, rather than performing cellular destruction themselves clinically. Option C is incorrect because B memory cells store information for faster future responses, rather than killing currently infected cells. Their role involves recognition and rapid antibody production upon re-exposure, rather than direct cytotoxic membrane destruction. Cytotoxic T cells are the assassins of the immune system, and they have a very specific job during viral infections. When a virus enters a body cell and starts replicating, antibodies cannot reach inside to stop it. The virus is hiding behind the cell's own membrane, using the cell's machinery to make more viruses. The only way to stop viral replication at that point is to destroy the infected cell itself. That is where cytotoxic T cells, also called CD8 T cells or killer T cells, take over. Infected cells display fragments of viral protein on their surface through MHC class I markers. Cytotoxic T cells scan cells for these flags. When a CD8 T cell finds a match, it binds to the infected cell and releases perforin and granzymes. Perforin punches holes in the cell membrane. Granzymes enter through those holes and trigger programmed cell death in the infected cell. The infected cell dies before the virus can finish replicating, stopping viral spread. Option A is wrong, because plasma cells make antibodies, which cannot reach viruses hiding inside host cells. Option B is wrong because helper T cells coordinate other immune responses through cytokines rather than killing directly. Option C is wrong, because B memory cells store information rather than performing cytotoxic action. Here's a WEGU D236 OA exam tip for you. Remember cytotoxic T cells as CD8 equals cell destroyers. 8 sides of the cell get punctured by perforin. CD8, UA2 cell destroyer, perforin punctures, infected cell dies. Question 34. A pediatric clinic patient receives her second dose of a vaccine 6 months after the initial shot. Her body mounts a faster, stronger response, producing more antibodies within days compared to the slower initial response. Which immunological principle best explains this improved secondary reaction? A. Memory cells enable faster, stronger secondary responses. B. Primary vaccines cause permanent antibody production baseline. C. Adjuvants in second dose boost natural killer activity. D. Hunt. Complement system activation becomes enhanced permanently after exposure.
Do you know the answer?
Correct answer. A. Memory cells enable faster, stronger secondary responses. Primary vaccine exposure creates memory B and T cells that persist long-term. Upon second exposure, these memory cells rapidly activate and multiply, producing more antibodies faster than the slower initial response. This forms the basis of how vaccines work. Option B is incorrect, because primary vaccines do not cause permanent baseline antibody production. Initial antibody levels gradually decline over time, and the secondary response relies on memory cells reactivating rather than continuous antibody production from the first exposure. Option C is incorrect, because adjuvants enhance general immune activation rather than specifically boosting natural killer cell activity. The stronger secondary response stems from memory cell reactivation rather than enhanced innate cellular components like natural killer cells. Option D is incorrect, because complement system activity does not become permanently enhanced after a single exposure. The complement cascade operates through innate immunity and does not develop memory-based improvements, like the adaptive immune system does specifically. Vaccine boosters work because of one specific biological mechanism, and it all comes down to memory cells. The first time a vaccine enters the body, the immune system treats the antigen like a new invader. It takes about 10 to 14 days to build a full antibody response, because B and T cells have to find the right match, multiply, and differentiate. Antibody levels rise slowly, peak, then gradually fade over months. But during that first exposure, the body creates memory B cells and memory T cells that live for years. When the second dose arrives 6 months later, memory cells recognize the antigen almost instantly. They activate and multiply far faster than the first round. Antibody levels climb higher and sooner, sometimes within days instead of weeks. This is why two-dose vaccines produce stronger and longer-lasting protection than single doses. Option B is wrong, because primary vaccines do not create permanent baseline antibody production. Antibody levels actually drop over time if memory cells are not re-triggered. Option C is wrong, because adjuvants help the initial dose work better by activating innate immunity, but the faster second response comes from memory cells, not adjuvants in the booster. Option D is wrong, because the complement system is part of innate immunity and does not build lasting memory in the way the adaptive system does. Here's a D236 OA exam tip for you. Think of boosters as memory makes it faster. First dose teaches, second dose activates memory. Memory makes it faster means higher antibodies, sooner. Memory TB speed strength. Question 34. A pediatric clinic patient receives her second dose of a vaccine 6 months after the initial shot. Her body mounts a faster, stronger response, producing more antibodies within days compared to the slower initial response. Which immunological principle best explains this improved secondary reaction? A. Memory cells enable faster, stronger secondary responses. B. Primary vaccines cause permanent antibody production baseline. C. Adjuvants in second dose boost natural killer activity. D. Complement system activation becomes enhanced permanently after exposure. Correct answer: A. Memory cells enable faster, stronger secondary responses. Primary vaccine exposure creates memory B and T cells that persist long-term. Upon second exposure, these memory cells rapidly activate and multiply, producing more antibodies faster than the slower initial response. This forms the basis of how vaccines work. Option B is incorrect, because primary vaccines do not cause permanent baseline antibody production. Initial antibody levels gradually decline over time, and the secondary response relies on memory cells reactivating rather than continuous antibody production from the first exposure. Option C is incorrect, because adjuvants enhance general immune activation rather than specifically boosting natural killer cell activity. The stronger secondary response stems from memory cell reactivation rather than enhanced innate cellular components like natural killer cells. Option D is incorrect, because complement system activity does not become permanently enhanced after a single exposure. The complement cascade operates through innate immunity and does not develop memory-based improvements, like the adaptive immune system does specifically. The elderly immune paradox has a clean explanation in naive T cells. As people age, the thymus, which is the organ that trains T cells, shrinks dramatically. By age 60 or 70, the thymus produces far fewer new T cells than it did in childhood. New T cells that have never seen an antigen are called naive T cells. These are the ones available to respond to brand new pathogens the body has never encountered before. With fewer naive T cells in circulation, elderly patients struggle to mount strong responses to novel threats like COVID-19, which was genuinely new to every immune system. At the same time, memory T cells that formed earlier in life against previously encountered viruses like ON1 or seasonal flu strains remain well preserved. Memory cells do not depend on thymus function and can survive for decades in lymphoid tissue. When an elderly patient encounters an old enemy their body has seen before, memory cells jump into action just as effectively as they did 30 years ago. This explains why the same senior can barely fight off COVID-19 while breezing past ON1. Novel pathogens need naive T cells the aging body lacks. Familiar pathogens meet memory cells the aging body still has. Option A is wrong because complement changes do not selectively affect only new pathogens. Option B is wrong because memory-based antibody responses to familiar viruses often remain strong in elderly patients. Option D is wrong because innate immunity does not vanish with age. Here's a Wagyu D236 OA exam tip for you. Connect aging to T cells using the phrase, old cells remember, new cells disappear. Memory stays, naive shrinks. Old cells remember, new cells disappear equals strong for old, weak for new. Question 36. A medical student explains bone remodeling to a patient with osteoporosis. She describes two cell types working together, one tearing down old bone while the other builds new bone. Which statement correctly identifies the specific function of each cell type in this process? A. Both cells exclusively build new bone tissue daily. B. Osteoclasts tear down bone while osteoblasts build it. C. Chondrocytes break down bone while osteocytes form it. D. Osteoblasts break down bone while osteoclasts form it.
What do you think is the answer?
Correct answer, B. Osteoclasts tear down bone while osteoblasts build it. Osteoclasts function as the demolition team, breaking down old bone and releasing calcium into the bloodstream. Osteoblasts act as the construction team, secreting osteoid matrix and mineralizing it with calcium and phosphate to build new bone tissue. Option A is incorrect, because the two cell types have opposite roles, rather than identical building functions. This answer ignores the essential balance between breakdown and formation that characterizes normal bone remodeling throughout the lifespan physiologically. Option C is incorrect, because chondrocytes are cartilage cells rather than bone-breaking cells, and osteocytes are mature bone cells rather than bone-forming cells. These labels misidentify the actual cellular players involved in active bone remodeling processes. Option D is incorrect, because this reverses the actual functions of the two cell types. Osteoblasts build bone while osteoclasts break it down, making this answer a common test distractor that students who confuse the names often select mistakenly. Bone remodeling runs on two opposite cell crews, and they have a clever balance going most of the time. Bone is not a static structure. It constantly breaks down and rebuilds itself throughout life. Two cell types drive this process, and each does the opposite of the other. Osteoclasts are the demolition team. They dig into old or damaged bone, dissolve the mineral content, and release calcium into the bloodstream. Think of them as bulldozers breaking up pavement. Osteoblasts are the construction team. They lay down fresh osteoid matrix, the protein framework of new bone, and then mineralize it with calcium and phosphate to make it hard. When these two crews work at equal pace, bone stays strong and the blood calcium stays balanced. When osteoclasts outpace osteoblasts, bone weakens, which is what happens in osteoporosis. When osteoblasts outpace osteoclasts, bone can become abnormally dense, as seen in Paget disease. Option A is wrong because the two cell types have opposite roles rather than identical ones. Option C is wrong because chondrocytes make cartilage, not break down bone, and osteocytes are mature bone cells embedded in bone rather than bone builders. Option D is the classic trap answer because it reverses the two correct cell functions. This confusion is exactly why students memorize the names carefully. Here's a D236 OA exam tip for you. Sort the C and B using clasts crush, blasts build. Osteoclast starts with C for crush. Osteoblast starts with B for build. Clasts crush, blasts build. Never mix them up on test day. Question 37. A patient with chronic kidney disease develops low serum calcium levels along with tingling around her mouth and muscle cramps. Her parathyroid glands respond appropriately to this situation. Which specific actions would parathyroid hormone take to correct her calcium imbalance in the body? A. Stimulate osteoclasts and increase vitamin D activation. B. Stimulate osteoblasts and decrease intestinal calcium uptake. C. Release calcitonin from thyroid to deposit calcium. D. Suppress kidney calcium reabsorption to normalize levels.
Can you guess the answer?
Correct answer. A. Stimulate osteoclasts and increase vitamin D activation. Parathyroid hormone responds to low calcium by stimulating osteoclast activity to release calcium from bone, while also activating vitamin D to enhance calcium and phosphate absorption from the intestine and kidney, thereby raising blood calcium effectively. Option B is incorrect because PF stimulates osteoclasts rather than osteoblasts during low calcium states, and it increases rather than decreases intestinal calcium absorption. This combination reverses the actual physiological responses to hypocalcemia clinically. Option C is incorrect because calcitonin is released from the thyroid during high calcium states rather than low ones. Calcitonin opposes PT action and deposits calcium into bone, making it the wrong hormone for correcting hypocalcemia specifically. Option D is incorrect because PTF enhances rather than suppresses kidney calcium reabsorption during hypocalcemia. Increased reabsorption helps retain calcium in the blood, making suppression the opposite of what this hormone actually does physiologically. When calcium drops low, parathyroid hormone kicks into gear with a coordinated multi-organ rescue plan. 4 tiny parathyroid glands sit on the back of the thyroid and constantly sample blood calcium levels. When calcium drops below the normal range, these glands release parathyroid hormone, or PF, into circulation. PT acts on 3 targets at once to pull calcium back up. First, it stimulates osteoclasts in bone. Osteoclasts break down bone matrix and release calcium into the blood. This gives an immediate calcium boost from the body's largest calcium storage site. Second, PT acts on the kidney in 2 ways. It tells the kidney to reabsorb more calcium from the filtrate instead of losing it in urine. It also activates vitamin D by converting it to its active form, calcitriol. Third, activated vitamin D then travels to the intestines and tells them to absorb more calcium from food. All 3 actions work together to raise blood calcium. This patient with chronic kidney disease has low calcium partly because her diseased kidneys cannot activate vitamin D well, so her PF keeps pumping without enough result. Option B reverses 2 things. PTeth stimulates osteoclasts, not osteoblasts, and it increases rather than decreases intestinal calcium absorption. Option C is wrong because calcitonin is the hormone that responds to high calcium, not low. Option D is wrong because PTF enhances kidney calcium reabsorption rather than suppressing it. Here's a D236 OA exam tip for you. Remember PF as pull the hormone for low cat. PTeth pulls calcium from bone, kidney, and gut. Pull the hormone Chi, pull Ka from 3 places. Question 38. An endocrinology lecturer describes a hormone that does the opposite of parathyroid hormone by responding to high blood calcium levels and pushing calcium back into bone. Which specific hormone source and action combination best matches this description during normal physiological function? A. Thyroid hormone suppressing osteoclast activity generally. B. Parathyroid hormone stimulating osteoblast activity during hypocalcemia. C. Calcitonin from thyroid inhibiting osteoclasts and stimulating, and D. Hostanon, adrenocortisol promoting bone resorption during stress.
Can you guess the answer?
Correct answer, C. D. Calcitonin from thyroid inhibiting osteoclasts and stimulating. Calcitonin comes from the thyroid gland and responds to high blood calcium. It inhibits osteoclast activity and stimulates osteoblasts, moving calcium from blood back into bone. This makes calcitonin the physiological opposite of parathyroid hormone in calcium regulation. Option A is incorrect because general thyroid hormone like T3 and T4 regulates metabolism rather than calcium balance specifically. While technically from the thyroid, these hormones do not perform the specific calcium-lowering actions described in the question. Option B is incorrect because PTH does the opposite of what is described. PTH responds to low calcium by stimulating osteoclasts to release calcium from bone, rather than pushing calcium back into bone during high levels. Option D is incorrect because cortisol actually promotes bone breakdown rather than building, and it does not specifically respond to calcium levels. Chronic cortisol elevation contributes to osteoporosis, rather than correcting high blood calcium states appropriately. Calcitonin is the mirror image of PT, and it has a straightforward job when blood calcium climbs too high. The thyroid gland contains specialized C cells, also called parafollicular cells, that constantly monitor blood calcium. When calcium levels rise above the normal range, these C cells release calcitonin into the bloodstream. Calcitonin pushes calcium back into bone to lower blood levels. It does this through two coordinated actions. First, calcitonin inhibits osteoclast activity. Without osteoclasts actively breaking down bone, calcium stops leaking out of the skeleton into the blood. Second, calcitonin stimulates osteoblast activity. Osteoblasts grab calcium from the blood and build it into new bone matrix, pulling calcium out of circulation. Together, these two actions lower blood calcium back toward normal. Notice the symmetry with PTH, but PTH raises calcium by stimulating osteoclasts and inhibiting bone building. Calcitonin lowers calcium by doing the opposite. The two hormones work as a pair to keep blood calcium steady. Option A is wrong because T3 and T4 from the thyroid regulate metabolism rather than calcium levels, even though they also come from the thyroid. Option B is wrong because PTH responds to low calcium and activates osteoclasts, which is the opposite of what the question describes. Option D is wrong because cortisol actually breaks down bone over time, rather than depositing calcium into it. Here's a WGD D236 OA exam tip for you. Connect calcitonin to its role using calcitonin means tone down calcium. High calcium goes into bone and gets toned down. Calcitonin tone down Chi and Cha into bone. Question 39. A pediatric patient with dietary vitamin D deficiency develops soft, bowed leg bones despite having osteoblasts that are still actively producing osteoid matrix. Which specific process becomes impaired by this vitamin deficiency that leads to the characteristic bone deformities seen in this condition? A. Osteoclast activity increases without any compensating mechanism. B. Osteoblast death accelerates during calcium absorption periods. C. Bone marrow function decreases blood cell production markedly. D. Calcium and phosphate absorption fails to mineralize.
Do you know the answer?
Correct answer, D. Calcium and phosphate absorption fails to mineralize. Vitamin D normally helps absorb calcium and phosphate from the intestine for bone mineralization. Without adequate vitamin D, osteoblasts continue producing osteoid, but cannot mineralize it properly due to insufficient calcium and phosphate availability for proper deposition. Option A is incorrect, because rickets results from failed mineralization rather than excess osteoclast activity. Osteoblasts are still working but cannot incorporate calcium properly, making the problem one of deficient building material rather than increased breakdown. Option B is incorrect, because osteoblasts continue functioning and producing osteoid in rickets rather than dying accelerated. The osteoided matrix accumulates without proper mineralization, which differs from accelerated cell death in bone-forming populations clinically. Option C is incorrect, because vitamin D deficiency primarily affects bone mineralization rather than bone marrow function. Blood cell production remains relatively normal, with the pathology centered on impaired calcium deposition into existing osteoid matrix specifically. Rickets shows what happens when osteoblasts build but cannot mineralize, and vitamin D sits at the center of the problem. Osteoblasts build bone in 2 steps. First, they secrete osteoid, a soft protein framework made mostly of collagen. Second, they mineralize that framework by pulling in calcium and phosphate to make the bone hard and rigid. That mineralization step is where vitamin D becomes essential. Vitamin D's main job in bone health is helping the intestine absorb calcium and phosphate from food. Without adequate vitamin D, calcium and phosphate absorption drops. The osteoblasts keep laying down osteoid matrix as usual, but there is not enough mineral available to harden it. The result is bones that are soft, weak, and bend under normal weight-bearing stress. In growing children, this soft bone deformity shows up most dramatically in the leg bones, which have to support body weight. The legs bow outward or inward, and the growth plates become widened and irregular. Option A is wrong, because rickets is a mineralization problem rather than an osteoclast overactivity problem. Bones in rickets are soft, not excessively broken down. Option B is wrong, because osteoblasts continue functioning in rickets rather than dying. The problem is what they cannot finish doing, not that they stop working. Option C is wrong, because vitamin D deficiency primarily affects bone mineralization rather than bone marrow function. Blood cell production remains relatively normal. Here's a what you do D236 OA exam tip for you. Remember rickets as soft bones, missing minerals. Vitamin D missing, calcium missing, bone stays soft. Soft bones, missing minerals equals bowed legs, rickets. Question 40. A postmenopausal woman undergoes bone density screening and receives an osteoporosis diagnosis. Her doctor explains that her bone loss resulted from an imbalance between 2 ongoing processes rather than a single problem. Which specific cellular imbalance best describes what is happening in her skeleton? A. Osteoclast activity exceeds osteoblast activity over time. B. Osteoblasts work harder than osteoclasts build excess bone. C. Vitamin D production by skin decreases during aging rapidly. D. Parathyroid hormone levels become suppressed, causing calcium retention.
Can you guess the answer?
Correct answer, A. Osteoclast activity exceeds osteoblast activity over time. Osteoporosis develops when bone breakdown by osteoclasts exceeds new bone formation by osteoblasts over time. Estrogen deficiency after menopause accelerates this imbalance, resulting in decreased bone density, increased porosity, and heightened fracture risk seen clinically. Option B is incorrect, because osteoporosis involves excess breakdown rather than excess building. If osteoblasts outpaced osteoclasts, bones would become denser rather than weaker, which represents the opposite of what osteoporosis actually produces clinically. Option C is incorrect, because while vitamin D deficiency can contribute, it primarily causes osteomalacia through failed mineralization rather than osteoporosis through imbalanced remodeling. These conditions share some features but have different underlying mechanisms fundamentally. Option D is incorrect because suppressed PTH would not typically cause osteoporosis. The condition more commonly relates to estrogen deficiency after menopause and normal aging rather than specific parathyroid hormone suppression, which would produce different clinical findings entirely. Osteoporosis is basically a demolition versus construction imbalance, and this postmenopausal patient fits the pattern perfectly. Throughout life, osteoclasts and osteoblasts work as a team. Osteoclasts break down old bone. Osteoblasts build new bone. When the two cell types work at the same pace, bone density stays steady and strong. In osteoporosis, that balance breaks. Osteoclasts keep doing their job at the usual rate or even faster, while osteoblasts start to lag behind. Over months and years, more bone gets removed than gets replaced. The result is thinner, more porous bones that fracture easily under stresses that would not have bothered them before. Estrogen is a key player here. Before menopause, estrogen helps restrain osteoclast activity, keeping the balance tilted slightly toward building. After menopause, estrogen levels drop sharply. Osteoclasts lose that break, and bone breakdown speeds up while bone formation stays the same or slows. The net effect is accelerated bone loss, which is why postmenopausal women are the highest risk group for osteoporosis. Option B is backwards, because osteoporosis is a disease of too much breakdown, not too much building. If osteoblasts were winning, bone would get denser, not weaker. Option C is close, because aging vitamin D decline contributes, but vitamin D deficiency causes osteomalacia through failed mineralization rather than osteoporosis through imbalanced remodeling. Option D is wrong because suppressed PTH does not cause osteoporosis. The disease relates more to estrogen loss. Here's a D236 OA exam tip for you. Link osteoporosis to the phrase clasts win, bones thin. When demolition outpaces construction, bones lose mass. Clasts win equals bones, thin equals osteoporosis. Fractures follow. Question 41. A construction worker sustains a closed tibia fracture after falling from scaffolding. His orthopedic surgeon explains that his bone will heal through several predictable stages over coming months. Which correct sequence best describes the stages of bone healing following his traumatic injury? A. Remodeling comes first, then inflammation and callus. B. Callus formation precedes all inflammation and healing. C. Inflammation, granulation, callus, deposition, remodeling. D. Granulation, remodeling, inflammation, deposition, callus.
Can you guess the answer?
Correct answer, C. Inflammation, granulation, callus, deposition, remodeling. Bone healing follows 5 predictable stages in order. First comes inflammation with hematoma formation. Then granulation tissue develops, followed by callus formation, lamellar bone deposition, and finally remodeling. Full bone strength returns roughly 3 to 6 months after injury. Option A is incorrect, because remodeling is the final stage rather than the first. Inflammation must occur initially to recruit healing cells and form the hematoma that provides the foundation for subsequent healing stages in bone. Option B is incorrect because callus formation comes after inflammation and granulation tissue have developed. The sequence progresses through ordered stages rather than skipping directly to callus before the foundational healing processes have taken place. Option D is incorrect because this order rearranges the actual healing sequence incorrectly. Granulation cannot come first because it requires inflammation to bring cells to the site, and remodeling must come last rather than early in healing. Bone healing moves through 5 predictable stages, and getting the order right is one of the cleanest test questions in musculoskeletal pathophysiology. The moment a bone breaks, the body kicks off stage 1. Inflammation starts within hours. Blood vessels tear, bleeding begins, and a hematoma forms around the fracture site. Inflammatory cells flood in to clean up debris and release chemical signals that call in the next wave. Stage 2 is granulation. Over the next few days, the hematoma gets replaced by soft granulation tissue, a meshwork of new capillaries and fibroblasts that lays the foundation for repair. Stage 3 is callus formation. Fibroblasts and chondrocytes build a soft cartilage-like bridge between the broken ends. This soft callus gives the fracture its first rough stability, usually within 2 to 3 weeks. Stage 4 is deposition. Osteoblasts arrive in force and replace the soft callus with hard lamellar bone. The fracture is now solid enough to bear weight, though not yet at full strength. Stage 5 is remodeling, the longest stage. Osteoclasts and osteoblasts refine the shape of the new bone, aligning the internal structure along stress lines. Full strength typically returns 3 to 6 months after the original injury. Option A is wrong because remodeling is the last stage, not the first. Option B is wrong because callus cannot form before inflammation brings in the cells to build it. Option D is wrong because this order scrambles the sequence, putting granulation before inflammation and remodeling before deposition. Here's a D236 OA exam tip for you. Memorize the order as I got cast. Doc remodels. Inflammation, granulation, callus, deposition, remodeling. IGCDR. I got cast. Doc remodels. Question 42. A basketball player rolls her ankle during a game and cannot bear any weight on the injured side. Physical examination reveals complete loss of joint stability with severe pain. Which grade of sprain best describes this specific presentation with complete ligamentous disruption and functional loss? A. Grade 3, complete tear loss of function. B. Grade I, microscopic tearing with slight swelling. C. Grade 2, partial tear with moderate symptoms. D. Grade 4, chronic degenerative ligament damage.
What do you think is the answer?
Correct answer. A. Grade 3, complete tear loss of function. Grade 3 sprains involve complete ligament tears with severe pain, loss of joint function, and inability to bear weight. The player's presentation of no weight-bearing ability with joint instability matches this severe grade rather than milder partial tear categories. Option B is incorrect, because grade I sprains involve only microscopic tearing with slight swelling and preserved joint function. Patients with grade I injuries typically can still bear weight and move the joint normally without severe instability. Option C is incorrect because grade 2 sprains involve partial tears with moderate swelling and reduced but not absent joint function. The described inability to bear any weight and complete instability go beyond grade 2 injury severity clinically. Option D is incorrect, because grade 4 does not exist in the standard sprain grading system. Sprains are classified from grade I through grade 3 based on severity of ligament damage, with grade 3 being the most severe. Sprain grading comes down to how much of the ligament actually tore, and this basketball player sits at the top of the scale. Sprains are injuries to ligaments, the tough, fibrous bands that connect bone to bone at joints. Clinicians grade sprains on a 3-point scale based on how much fiber damage occurred. Grade 1 is a microscopic tear. The ligament fibers stretch or tear at the cellular level, but the overall ligament stays intact. Patients feel mild pain, see a little swelling, and usually keep walking on the joint. Grade 2 is a partial tear. More fibers tear, but enough remain connected to hold the joint together in some form. There is moderate pain, more swelling, visible bruising, and some loss of joint function, but weight bearing is still possible with care. Grade 3 is a complete tear. The ligament is fully disrupted, with no continuity between the two ends. The joint loses stability entirely. Severe pain, major swelling, and inability to bear weight define this grade. That is exactly what this player presents with. Complete instability plus no weight bearing equals grade 3. Option B is wrong, because grade 1 allows continued function with only mild symptoms. Option C is wrong because grade 2 shows reduced but not absent joint function. Option D is wrong because grade 4 does not exist in the standard grading scale. Sprains stop at 3. Here's a What Do You D236 OA exam tip for you. Remember sprain grades as 1 is small, 2 is some, 3 is torn. Grade 1 small tear, grade 2 some fibers, grade 3 totally torn. 1 small, 2 some, 3 torn. Question 43. A nurse cares for a patient with a newly casted forearm fracture. During assessment, she notices cool fingers, pale skin below the cast, severely delayed capillary refill, and complaints of increasing pain with passive finger movement. Which complication should she suspect immediately and act upon? A. Compartment syndrome requiring emergent surgical intervention. B. Normal post-casting swelling that resolves spontaneously. C. Minor allergic reaction to cast material synthetic. D. Fat embolism syndrome, presenting atypically through extremity.
Can you guess the answer?
Correct answer, A. Compartment syndrome requiring emergent surgical intervention. Compartment syndrome presents with pain out of proportion to injury, pallor, paresthesias, pulselessness, and cool temperature distal to the affected area. These findings require immediate fasciotomy to prevent permanent nerve and tissue damage within 4 to 6 hours. Option B is incorrect because normal post-casting swelling does not cause severe pallor, cool temperature, and pain with passive movement. These specific findings point toward compartment syndrome, rather than expected post-injury tissue swelling that resolves without intervention. Option C is incorrect because allergic reactions to cast material typically cause itching, rash, or skin irritation, rather than the severe vascular compromise described. The neurovascular findings point towards circulatory and nerve impairment, rather than a hypersensitivity response. Option D is incorrect because fat embolism syndrome typically presents with altered mental status, respiratory distress, and petechiae over the chest and neck, rather than isolated extremity findings. The described presentation fits compartment syndrome specifically, rather than fat embolism. Compartment syndrome has a warning signature that nurses recognize within seconds, and this patient is flashing every one of them. A compartment is a group of muscles, nerves, and blood vessels bundled together inside a tough fascial envelope. The fascia has almost no stretch. When pressure builds inside a compartment from swelling, bleeding, or a tight cast, the pressure cannot escape outward. Instead, it squeezes blood vessels and nerves inside the compartment until blood flow cuts off and nerve function starts to fail. The classic warning signs are the 5 Ps. Pain out of proportion to the injury, especially pain with passive stretching. Pallor, from lost blood flow. Paresthesias, which are tingling or numb sensations. Pulselessness, as arterial flow drops. Poikilothermia, meaning the limb turns cool because blood is not reaching it. This patient shows cool fingers, pallor, delayed capillary refill, and pain with passive finger movement. Every sign points straight at compartment syndrome. The time window is narrow. Without fasciotomy to open the compartment and relieve pressure, tissue can die within 4 to 6 hours, leading to permanent nerve damage or limb loss. Option B is wrong because normal post-casting swelling does not cause pallor or cool temperature. Option C is wrong because allergic reactions produce itching and rashes rather than vascular compromise. Option D is wrong because fat embolism usually presents with altered mental status, respiratory distress, and chest petechiae, not isolated limb findings. Here's a What Do You D236 OA exam tip for you. Memorize the 5 Ps's: pain, pallor, paresthesia, pulselessness, poikilothermia. 5 Ps, 4 to 6 hours, call the surgeon. 5 Ps equals emergency fasciotomy now.o. Question 44. A pediatric emergency physician evaluates a 6-year-old with a suspected arm fracture after falling from playground equipment. The X-ray shows a partial break with the bone bent on one side while remaining intact on the opposite side. Which fracture type does this classic pediatric pattern represent? A. Comminuted fracture with multiple bone fragments visible. B. Greenstick fracture with partial break bending intact. C. Avulsion fracture where ligament pulled away bone. D. Compression fracture from axial loading crushing vertebra.
What do you think is the answer?
Correct answer. B. Greenstick fracture with partial break bending intact. Greenstick fractures occur when a partial break allows the intact portion of the bone to bend rather than break completely. This pattern appears almost exclusively in children because their bones remain relatively soft and flexible compared to adult bone density. Option A is incorrect, because comminuted fractures involve multiple bone fragments with several visible fracture lines, which does not match the described partial break with intact opposite side. These fractures typically result from high-energy trauma in adults rather than pediatric falls. Option C is incorrect, because avulsion fractures involve a fragment of bone being pulled away by an attached ligament, muscle, or tendon. This mechanism differs from the partial bending pattern seen in greenstick fractures of the growing pediatric skeleton. Option D is incorrect, because compression fractures result from axial loading that crushes the bone, typically affecting vertebrae in elderly osteoporotic patients. This mechanism does not match the bending pattern seen in pediatric long bone greenstick injuries. Greenstick fractures only happen in young bones, and understanding why helps you spot them on pediatric X-rays. Children's bones have a different composition than adult bones. They contain a higher proportion of organic collagen matrix and a lower proportion of mineralized hard material. That mix makes pediatric bone soft, springy, and flexible compared to adult bone, which is more rigid and brittle. When a force bends a child's bone past its limit, the bone often behaves like a fresh green stick off a tree. One side of the stick snaps under tension, while the other side simply bends without breaking. The result is a partial fracture on the tension side of the bone, with the compression side remaining intact but curved. This 6-year-old's X-ray showing a partial break with bone bent on one side and intact on the other fits the greenstick pattern exactly. Greenstick fractures are almost exclusive to pediatric patients because adult bone is too rigid to bend without snapping all the way through. Option A is wrong because comminuted fractures show multiple separate fragments of broken bone, typically from high-energy adult trauma rather than a pediatric fall. Option C is wrong because avulsion fractures happen when a tendon or ligament pulls a small piece of bone off its attachment site, which is a different mechanism. Option D is wrong because compression fractures crush the vertebrae from axial loading, which is typical in elderly osteoporotic spines rather than pediatric long bones. Here's a D236 OA exam tip for you. Remember, greenstick is kids bend like green twigs. Young bone bends, old bone breaks. Greenstick equals partial break, one side bent. Question 45. A soccer player takes a direct kick to her quadriceps during a game and develops immediate bruising, swelling, and localized pain in the thigh without any bone involvement. Which musculoskeletal injury type best describes this specific presentation resulting from direct blunt force trauma? A. Grade 3, ligament sprain complete tear. B. Greenstick fracture within soft muscle tissue. C. Muscle contusion with crushed fibers bleeding. D. Stress fracture from repetitive overload cumulative.
Can you guess the answer?
Correct answer. C. Muscle contusion with crushed fibers bleeding. Muscle contusions result from direct impact that crushes muscle fibers and small blood vessels, producing characteristic bruising with bluish appearance, swelling, and localized pain. The bleeding under the skin creates the visible discoloration commonly called a bruise clinically. Option A is incorrect, because grade 3 sprains involve complete ligament tears at joints rather than muscle fiber damage from direct blows. The injury described affects muscle tissue in the thigh rather than joint ligaments specifically. Joint ligaments specifically. Option B is incorrect because green stick fractures affect bone rather than muscle tissue, and the question specifies no bone involvement. This pediatric fracture pattern does not apply to soft tissue injuries resulting from direct blunt force trauma. Option D is incorrect because stress fractures develop gradually from repetitive overload rather than single acute impact events. This soccer player's injury resulted from one direct kick rather than cumulative overuse over time, making stress fracture incorrect. Direct blunt force to muscle produces a specific injury pattern, and a muscle contusion is the textbook answer here. When a soccer player takes a direct kick to the thigh, the impact crushes muscle fibers and the small blood vessels running through them. The crushed fibers release inflammatory signals, and the damaged capillaries leak blood into the surrounding tissue. That leaked blood pools under the skin, producing the characteristic bluish bruise, or ecchymosis, that shows up over the next few hours. Swelling develops as the body sends inflammatory fluid to the injury site to begin healing. Localized pain comes from both the tissue damage itself and the pressure from accumulating fluid. Because the injury affects soft tissue without breaking any bones, imaging would show no fracture line, only soft tissue swelling. The mechanism, a direct blunt impact on a specific muscle group, and the findings, bruising plus swelling plus pain without bone involvement, match a muscle contusion exactly. Option A is wrong, because a grade 3 sprain involves ligament tearing at a joint rather than muscle fiber damage from a direct blow. The injury described is in the muscle belly, not at a joint. Option B is wrong because green stick fractures affect bone and require bony involvement by definition. The question specifies no bone involvement. Option D is wrong because stress fractures develop gradually from repetitive loading over weeks or months. This injury happened in one moment from a single kick. Here's a D236 OA exam tip for you. Linked direct muscle impact to the phrase blunt hit, bruised muscle. Blunt blow crushes fibers and vessels. Bruising follows. Blunt hit equals muscle contusion equals bruise, swell, pain. Question 46. An 82-year-old woman falls getting out of bed at night and cannot stand afterward. At the hospital, her affected leg appears shortened and externally rotated compared to the unaffected side. Which underlying condition most likely contributed to this common elderly injury pattern? A. Underlying osteoporosis, weakening her proximal femur. B. Acute compartment syndrome, developing during sleep hours. C. Rheumatoid arthritis, destroying both hip joint surfaces. D. Paget disease causing rapid bone enlargement dramatically.
What do you think is the answer?
Correct answer. A. Underlying osteoporosis weakening her proximal femur. Hip fractures in elderly women most commonly result from underlying osteoporosis that weakens the proximal femur. 90% of hip fractures occur in people over 65, with a strong predominance in Caucasian postmenopausal women like this patient. Option B is incorrect because compartment syndrome does not typically occur spontaneously during sleep and does not cause shortening and external rotation of a limb. This complication follows trauma or surgery, rather than appearing as a sudden nocturnal, falling injury. Option C is incorrect because rheumatoid arthritis primarily affects smaller joints like hands and knuckles, rather than causing hip fractures from falls. While RA can eventually damage hip joints, it does not produce this specific fracture mechanism directly. Option D is incorrect, because Paget disease causes bone thickening and enlargement rather than the typical osteoporotic weakening that predisposes to hip fractures. This disease can increase fracture risk, but through different mechanisms than postmenopausal bone loss, specifically. Hip fractures in elderly women trace back to one common root cause, and the numbers tell the story. Around 90% of all hip fractures happen in people over age 65, with Caucasian postmenopausal women forming the highest risk group. The underlying reason is osteoporosis. After menopause, estrogen levels drop, which lets osteoclasts outpace osteoblasts in bone remodeling. Over years, bone density steadily falls, especially in the proximal femur where the bone is both trabecular and weight-bearing. The proximal femur becomes so weak that even minor forces, like rolling out of bed wrong or stepping off a curb, can snap the bone. The classic clinical picture is a shortened, externally rotated leg on the affected side. That appearance comes from muscle pulls acting on an unstable fracture. This 82-year-old fits that profile perfectly. Age over 65, female, and a simple fall from bed, leading to an inability to stand. Osteoporosis is the most likely reason her bone broke. Option B is wrong because compartment syndrome does not develop spontaneously during sleep and does not cause leg shortening and external rotation. Compartment syndrome follows trauma or surgery, not a nocturnal fall. Option C is wrong because rheumatoid arthritis mainly affects smaller joints like the hands and feet rather than causing sudden hip fractures from minor falls. Option D is wrong because Paget disease causes bone thickening and enlargement, not the weakness pattern that leads to low-energy hip fractures in this population. Here's a Wagyu D236 OA exam tip for you. Connect elderly hip fractures to the phrase thin bones, simple fall. Thin from osteoporosis, fall from anything small. Shortened externally rotated leg, QA classic sign. Thin bones, simple fall, snap goes hip. Question 47. A 70-year-old woman presents with gradual loss of height, a hunched posture, and acute upper back pain after simply bending to pick up a laundry basket. Imaging reveals a wedge-shaped thoracic vertebra ... Which underlying condition most likely caused this low-energy fracture pattern? A. Herniated disc pressing against spinal cord tissue. B. Lumbar strain from sudden back muscle tearing. C. Osteoporotic vertebral compression from weakened trabecular bone. D. Spinal cord tumor causing pathological vertebral collapse, acutely.
Do you know the answer?
Correct answer, C. Osteoporotic vertebral compression from weakened trabecular bone. Osteoporosis affects roughly 25% of postmenopausal women, increasing to 40% by age 80. Weakened trabecular bone collapses under normal loads, creating wedge-shaped vertebral compression, fractures with kyphosis, and height loss characteristic of this elderly population. Option A is incorrect, because herniated discs cause radiating nerve pain without vertebral deformity on imaging. The wedge-shaped vertebra described indicates structural bone collapse rather than disc pathology affecting nerve roots or spinal cord compression specifically. Option B is incorrect because lumbar strain involves muscle and ligament injury in the lower back rather than thoracic vertebral fracture. This diagnosis does not explain the imaging findings of a wedge-shaped compressed vertebra seen in this patient. Option D is incorrect because while tumors can cause pathological fractures, osteoporosis is far more common in elderly women and better explains the typical thoracic wedge compression pattern described. Tumors would usually show additional concerning imaging features beyond simple wedging. A wedge-shaped vertebra in an older woman almost always points straight at osteoporotic compression. Osteoporosis affects roughly 25% of postmenopausal women, and that number climbs to around 40% by age 80. The disease targets trabecular bone especially hard, and vertebral bodies are made primarily of trabecular bone. As the honeycomb structure inside the vertebra thins out, the vertebra loses the ability to handle normal compressive loads. A simple, everyday action like bending to pick up a laundry basket can generate enough downward force to crush the front portion of a weakened vertebra. Because the front of the vertebral body collapses more than the back, the bone takes on a wedge shape on imaging. Multiple wedge fractures stacked on top of each other tilt the spine forward, producing the gradual height loss and the hunched posture called kyphosis. This 70-year-old's presentation fits every piece of the picture. Gradual height loss over years, a hunched back, acute upper back pain after a trivial movement, and a wedge-shaped thoracic vertebra on imaging. Option A is wrong because herniated discs press on nerve roots and produce radiating pain rather than structural vertebral deformity. A wedge shape on imaging is a bone problem, not a disc problem. Option B is wrong because lumbar strain involves muscles and ligaments in the lower back rather than thoracic vertebral collapse. Option D is wrong because while tumors can cause pathological fractures, osteoporosis is far more common in this age group and produces the classic wedge compression pattern without the other imaging concerns tumors bring. Here's a D236 OA exam tip for you. Link wedge vertebra to the phrase wedge shape, weak spine. Weak from osteoporosis, wedged from collapse. Wedge shape, weak spine equals kyphosis, height loss. Question 48. A 65-year-old former marathon runner complains of worsening knee pain that improves with rest but returns after activity. X-rays show joint space, narrowing, and bony growths at the joint margins. Which pathophysiological process best explains these characteristic findings in her affected knee? A. Autoimmune attack, destroying synovial membrane throughout. B. Crystal deposition, causing intermittent inflammatory attacks acutely. C. Articular cartilage deterioration with osteophyte formation. D1. Bacterial infection spreading through joint space progressively.
Can you guess the answer?
Correct answer. C. Articular cartilage deterioration with osteophyte formation. Osteoarthritis develops when articular cartilage deteriorates in weight-bearing joints due to repetitive stress. This leads to subchondral bone changes, osteophyte formation at joint margins, and inflammation. Former athletes and overweight individuals face increased risk from cumulative joint loading over years. Option A is incorrect because autoimmune synovial attack describes rheumatoid arthritis rather than osteoarthritis. RA typically affects smaller symmetrical joints like hands and shows different imaging features including joint erosions rather than osteophyte formation at margins. Option B is incorrect because crystal deposition characterizes gout and pseudogout rather than osteoarthritis. These conditions produce acute inflammatory flares with specific crystal findings on joint aspiration rather than the chronic wear pattern with osteophytes described. Option D is incorrect because bacterial joint infection produces acute, severe pain, fever, and leukocytosis rather than the chronic wear pattern described. Septic arthritis requires immediate intervention and presents very differently from slowly progressive osteoarthritis clinically. Osteoarthritis builds up over decades of wear, and this former marathon runner shows the classic weight-bearing joint pattern. Osteoarthritis is a degenerative joint disease that starts with articular cartilage breakdown. Articular cartilage is the smooth, glassy surface that covers the ends of bones inside joints. It lets bones glide against each other with almost no friction during movement. Over years of repetitive loading, especially in high-impact activities like marathon running, the cartilage gradually wears thin. As cartilage deteriorates, the bone underneath it, called subchondral bone, starts taking more direct force. The subchondral bone responds by thickening and forming new bony projections called osteophytes at the joint margins. These osteophytes show up on X-rays as the bumpy outgrowths along the edges of the joint. The joint space itself narrows because there is less cartilage cushioning between the two bones. The clinical result is pain that gets worse with activity and eases with rest, along with stiffness after periods of inactivity. Her age, her marathon history, and her X-ray findings of joint space narrowing plus marginal osteophytes all fit osteoarthritis of the knee. Option A is wrong because autoimmune synovial attack describes rheumatoid arthritis, which affects smaller symmetrical joints and shows joint erosions rather than osteophyte formation. Option B is wrong because crystal deposition causes gout or pseudogout with acute inflammatory flares rather than the chronic wear pattern described. Option D is wrong because bacterial joint infection presents with fever, severe pain, and leukocytosis rather than years of gradual progression. Here's a D236 OA exam tip for you. Remember osteoarthritis as wear tear, bone spurs there. Cartilage wears, osteophytes form at edges. Wear tear, bone spurs there equals osteoarthritis on X-ray.U. Question 49. A warehouse worker develops sudden lower back pain after lifting a heavy box without proper technique. He reports sharp pain, muscle spasms, and limited range of motion but denies any radiating pain down his legs or numbness in his feet. Which diagnosis best fits this presentation? A. Cauda equina syndrome, requiring emergency surgery. B. Sciatica, with L5 so nerve root impingement. C. Spinal cord compression from traumatic fracture. D. Lumbar strain without neurological involvement present.
What do you think is the answer?
Correct answer. D. Lumbar strain without neurological involvement present. Lumbar strain presents with sharp pain, tenderness, and muscle spasms in the lumbar area without neurological symptoms. The absence of radiating pain down the legs and lack of numbness confirm the injury is confined to muscle or ligament tissue rather than nerve involvement. Option A is incorrect because Cauda equina syndrome presents with urinary or fecal incontinence, saddle anesthesia, and lower extremity weakness. This patient shows none of those emergency features, ruling out this surgical emergency diagnosis entirely in his presentation. Option B is incorrect because sciatica specifically involves radiating pain down the leg from nerve root impingement. This worker denies any radiating symptoms, which rules out nerve root compression as the primary diagnosis in his acute back injury. Option C is incorrect because spinal cord compression from traumatic fracture typically produces profound neurological deficits, numbness, and weakness below the level of injury. The absence of these findings makes simple muscular strain far more likely in this patient. Back pain without neurological signs narrows the diagnosis down quickly, and lumbar strain is the answer when the nerves are quiet. Lumbar strain is an injury to the muscles and ligaments of the lower back, usually from lifting something heavy with poor form or sudden awkward movement. The fibers in the muscle or ligament tear on a small scale, triggering inflammation and protective muscle spasm that locks up the area. Patients feel sharp, localized pain at the injured site, tenderness when the area is palpated, and significant stiffness or limited motion as the muscles clench to protect the injured tissue. Here is what makes this a pure muscle strain rather than a nerve problem. There is no pain radiating down his legs, no numbness, no tingling, and no weakness in his feet. Nerve involvement would show up as symptoms traveling along the path of a nerve root, typically down the leg or into the foot. Without those signs, the injury is confined to the soft tissues of the lower back. Option A is wrong, because Cauda equina syndrome is a surgical emergency that presents with saddle anesthesia, loss of bowel or bladder control, and weakness in both legs. This worker shows none of those red flag signs. Option B is wrong, because sciatica involves radiating pain down the leg from nerve root compression, and he specifically denies any radiating symptoms. Option C is wrong because spinal cord compression from a traumatic fracture would produce profound neurological deficits below the level of injury. His neurological exam is clean. Here's a D236 OA exam tip for you. Separate muscle from nerve using no radiation, no nerve. If the pain stays local and nothing shoots down the leg, the nerves are fine and the muscles are the problem. No radiation, no nerve equals lumbar strain. Question 50. A 58-year-old Caucasian woman, 10 years postmenopausal, lives a sedentary lifestyle, takes prednisone for chronic asthma, and smokes a pack daily. Her primary care physician orders bone density testing. Which combination of factors most significantly increases her risk for developing osteoporosis in the next few years? A. Being overweight and taking calcium supplements daily. B. Getting adequate sleep and maintaining consistent weight. C. Eating a high-protein diet and avoiding dairy products. D. Postmenopausal status, steroid use, smoking, inactivity.
What do you think is the answer?
Correct answer, D. Postmenopausal status, steroid use, smoking, inactivity. Osteoporosis risk factors include postmenopausal status from estrogen loss, chronic corticosteroid use like prednisone that decreases bone density, smoking which impairs bone healing, and sedentary lifestyle without weight-bearing exercise. This patient carries all 4 significant risk factors simultaneously. Option A is incorrect, because being overweight actually provides some protection against osteoporosis through increased mechanical loading on bones, and calcium supplements generally help rather than harm bone density. This combination reduces, rather than increases her risk. Option B is incorrect, because adequate sleep and weight stability are neutral factors rather than risk multipliers for osteoporosis. These lifestyle elements do not significantly contribute to the bone loss pattern seen in postmenopausal women at risk. Option C is incorrect, because while low dairy intake can reduce calcium consumption, high-protein diets alone do not significantly cause osteoporosis. This answer misses the more impactful risk factors that actually dominate this patient's clinical picture. Osteoporosis risk stacking is all about adding up the big offenders, and this patient carries 4 of them at the same time. 4 major risk factors drive postmenopausal osteoporosis, and she has every single one. First, postmenopausal status means her estrogen levels dropped years ago. Estrogen normally restrains osteoclast activity, so losing estrogen lets bone breakdown accelerate. Second, chronic corticosteroid use for her asthma. Prednisone and similar drugs interfere with osteoblast function, reduce calcium absorption from the gut, and increase calcium loss through the kidneys. Long-term steroid use is one of the most damaging medication effects on bone health. Third, smoking a pack a day. Nicotine and other tobacco chemicals reduce blood supply to bone, impair healing of normal microdamage, and decrease estrogen production. Fourth, a sedentary lifestyle. Weight-bearing activity signals osteoblasts to build new bone. Without that mechanical stimulus, bone density drops because there is no load telling the body to maintain it. 4 simultaneous risk factors put her at a dramatically increased odds of developing osteoporosis within the next few years, which is exactly why her doctor ordered bone density testing now. Option A is wrong because being overweight actually offers some mechanical protection to bones, and calcium supplements help rather than harm. Option B is wrong because adequate sleep and stable weight are neutral factors rather than risk multipliers. Option C is wrong because while low dairy reduces calcium, a high-protein diet alone does not meaningfully drive osteoporosis compared to the factors this patient actually has. Here's a D236 OA exam tip for you. Stack the risk factors using the Imbalances. Postmenopausal, steroids, smoking, inactivity. PSSI, 4 letters. 4 reasons her bones are at risk. PSI equals pick a scan soon immediately.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.